So you presented all the activities that were rolled out during the trying to controlling the outbreak of yellow fever. So you mentioned EPI and all the other activities and immunization. However, if I'm aware correctly, you also coordinate some vector control activities with the dengue team and the vector control. Could you explain a little bit more how is the coordination of having a multi-sectoral approach, and mostly when you have yellow fever so closely to an urban setting? So if you could describe a little bit more about it. Thank you.
May I answer in Portuguese? Ok. Ok. É tradicional no Brasil, na época do verão, nós trabalharmos todo o controle de vetor. E isso é uma coisa muito rotineira nas cidades brasileiras por conta da dengue. E naquele período não foi diferente. Houve todo um controle vetorial realizado. Porém, o que chamava atenção era mais o contato das pessoas com as áreas silvestres. Todos os casos, absolutamente todos os casos identificados de febre amarela em seres humanos tiveram como local provável de infecção áreas de mata, ou áreas próximas à mata. E o principal vetor envolvido era o vetor silvestre. Então, houve sim um controle vetorial no período, mas a característica principal era essa. E naquele período, houve uma articulação entre todas as esferas de governo, porque existem escritórios de vigilância nos municípios que trabalham de forma independente. O Estado trabalha numa lógica de coordenação desses escritórios municipais, porque existem cidades que são próximas, são muito próximas, elas não têm um limite claro, e o governo federal trabalhava também numa lógica interestadual, considerando que nós tínhamos pelo menos 4 estados que estavam envolvidos com casos de febre amarela. Então, houve todo um processo de articulação de todas as atividades de vigilância envolvendo todos os entes federados naquele período, algo que, inclusive, é feito sempre.
Thank you very much. We may have one more question.
Yes, thank you very much. My question still goes to Ede. My name is William Komakech. I'm from the WHO Regional Office for Africa. I work on the I strategy implementation. So my question is about the ecological corridors. Can you explain a little bit more what exactly are the ecological corridors and the role they play in extending transmission of yellow fever from the jungle to the fringes of the city? Thank you.
William, obrigado pela pergunta. No Brasil, nós temos 2 estratégias de resposta à identificação de casos de febre amarela. Seja febre amarela em primatas não humanos, seja febre amarela em humanos. A primeira estratégia, e a mais antiga, é você vacinar todo o município, fazer uma estratégia de catch-up em todo o município, envolvido com o caso, ou seja, onde foi identificado o caso, e fazer a mesma estratégia nos municípios do entorno, os vizinhos. Essa é a estratégia tradicional. A estratégia de corredor é quando nós identificamos alguns casos de primatas não humanos. E esses casos de primatas não humanos, eles são georreferenciados. Uma vez identificados esses primatas, nós cruzamos a posição desses primatas com os mapas de matas, de florestas. Porque no Brasil nós temos mapeado, através dos escritórios de meio ambiente, nós temos mapeado as florestas, os corredores ecológicos. Então, sabendo a posição dos primatas, nós conseguimos traçar os possíveis caminhos de disseminação do vírus pelos primatas. E aí nós sabemos também a amplitude de voo e a velocidade de voo dos mosquitos vetores. Então, nós traçamos vários corredores possíveis de disseminação do vírus, e esses corredores, eles são validados com o tempo, conforme nós identificamos novos casos de primatas com um avanço em onda da propagação do vírus. Então, isso permite uma certa previsão de onde a febre amarela, para onde a febre amarela vai. Porque lá no Brasil ela vai como uma onda, ela se propaga. Então, com isso, nós conseguimos vacinar preventivamente o possível caminho da febre amarela, que foi o que nós fizemos em 2017, 18, e aí nós colocamos o nosso plano como uma estratégia preventiva e de resposta à identificação de casos.
Thanks a lot for the questions, and thanks a lot also for the answers and for the presentations that have been so wonderful this morning.
Thank you, Aki, and welcome back from lunch, all our colleagues. I especially took extra lunch so that I can hold this to any latecomers. So we're going to start. Raman, are you ready?
Yes.
Please go ahead.
So should I upload the slide from here or okay? Thank you very much for giving me this opportunity.
Question and answer.
Okay, so I'm here to briefly discuss on existing and emerging tools to control Aedes mosquitoes. And before I plunge into the topic, I really want to highlight few key points, which due to time limitation, I haven't included it as a slide. The first point is that evidence base for Aedes control is rather weak, mainly due to lack of funding for large scale studies. And at the same time, the mosquito has silently spread across continents. Today, Aedes is present in over 150 countries. And this mosquito has got certain characteristics which are very, very unique compared to other mosquitoes. One is that their eggs can remain dry for several months and hatch when in contact with water. Second, they do bite several individuals in one go. So that leads to clustering of cases. And the third, which you all know, is that they are day biters. So these are really unique characteristics for Aedes for which we are really challenged. Now in WHO, we have a committee called Vector Control Advisory Group. That is what VCAG stands for. And Vector Control Advisory Group was created in 2012, and now it's over 10 years old, mainly to support WHO to guide applicants with new tools, and mainly to help them in study design and generate epidemiological data. It also supports WHO to evaluate the public health value of new vector control intervention. And it advises WHO on whether the public health intervention is well demonstrated. And then we take this recommendation to develop guidelines. Now this VCAG, as we call it, is jointly administered by the Global Malaria Program, the Global Neglected Tropical Disease Program, and the pre-qualification team. So there are 3 departments involved in managing VCAG. Next one, please. Now, what do I mean by evaluation pathway? So first of all, when there is a tool for vector control coming through the pipeline, we have a program, a PCC or a pre-submission coordination meeting involving the 3 departments. And we determine whether this tool is really a new one, which WHO has no recommendation yet, or whether it is an old tool like a different chemical, which, for example, for spraying, or a different type of mosquito net for which there is a recommendation. And accordingly, we allocate this to the pathway. The pathway on top, which we call the pre-qualification pathway, is really to determine the safety efficacy, and quality of the product. So they decide whether the product meets these three criteria. And if it is a tool which WHO has already got a recommendation, then it can go through the PQ pathway and get listed in the PQ website. At the same time, we have a policy in place already. Now, if it's a new tool, for example, then in that case, it has to go through the VCAG pathway, which is at the bottom, which involves a planning phase, and a VCAG, which really assesses the trial design and evaluates the results. Now, most of these innovators can come to VCAG several times. So it is really an advisory committee in WHO to fast track new tools and to develop policy, which is basically the responsibility of the department, mainly to develop recommendations, WHO recommendations for new tools. Next one, please. So for Addis control, what we really have currently are these new tools. First of all is a spatial repellent, which is a transfluthrin-based emanator. They have completed one study in Peru and the second study is ongoing. Then we have several traps which are under evaluation. The sterile mail technique, which I will elaborate later, they are also under evaluation. There is also the Wolbachia, which is a pathogen, which lives, a symbiotic bacteria which lives within the mosquito. And here, Wolbachia 1 strain has really completed the study with several, one randomized control study and several other studies were submitted to VCAG, and VCAG has recommended Wolbachia to have public health value. Next slide, please. So in the next slide, what you are going to see is the Wolbachia. So in Wolbachia, we have two types of Wolbachia. One is a Wolbachia, which is, you see the suppression strategy, which leads to the reduction of mosquito population. And currently this is being deployed in parts of Singapore. There are some trials in Puerto Rico, which was inconclusive, and there is also smaller studies ongoing, but we are really waiting for a good quality randomized controlled trial, which we hope will start soon because they have submitted some trial designs already. The second one, the replacement strategy, is the one which has been in contact with VCAG for past 8 years. They have submitted their full dossier. And what is most interesting is in one study in Indonesia, it has shown 77% reduction in dengue over a 27-month period, which is significant. They have also submitted 5 other trials of VCAG to VCAG, and also they are submitted more trials to the program, mainly to develop the recommendation. We are currently finishing the TPP, the target product profile for this Wolbachia. A systematic review has been completed, and we hope to have a recommendation soon on this particular Wolbachia. Now, the difference between the two is the replacement strategy means that this Wolbachia is self-propagating within the population. So what we are aiming for is to have an Addis population, which is about 70 to 80% infected with Wolbachia. And once it has the Wolbachia in its body, the bacteria basically stops the transmission of the virus within the body of the mosquito. So this is a significant advantage, that we can cut the transmission within the mosquito itself. Though it is there in nature, it will be reproducing and producing several offsprings, which are all Wolbachia infected. It has no harm to us, but the transmission is stopped. So this is a very positive tool, which we hope will get more evidence base and more stronger recommendations. Next one, please. Among the other tools, the spatial repellent is one which has just completed one study in Peru, showing a 33% reduction in dengue, and they are currently doing the second study, mainly for in VCAG, if they really want to come up with a public health recommendation, the VCAG needs at least a minimum of 2 studies. So we are waiting for the second study to go on. And this is a passive emanator, which is something like a patch. You can stick it on the wall and it repels the mosquito. So this is an intervention which has potential. And now the producer of the patch has indicated that they have developed patches which can last almost 1 year. So this is very encouraging. We hope things can, they can generate better evidence base in their second study. Next one, please. So in the next case, it is the sterile insect technique, which I briefly mentioned. It is basically a technique which many of you may be aware is used extensively in agriculture, mainly to sterilize the male population of the insect. And once you release the sterile males into the wild, they go and mate with the females, and the offsprings, all the eggs are not they are all sterile in a sense. They won't hatch. So there is this technique is being used with the help of the International Atomic Energy Agency, who are collaborating with us. There are several studies currently in progress, but basically large scale studies have not started. But you may know that in African trypanosomiasis, this method is extensively used to suppress the insect population. So this is another promising tool, which of course will involve releasing several batches of sterile males to make sure that there is a population reduction. So this is a tool which is also showing a lot of promise. Next one. Among the conventional tools which we have been continuously carrying out systematic review and grading with the help of Cochrane and independent methodologists. This grading was just completed. Basically, the first one is for targeted indoor spraying. What I mean by targeted indoor spraying is it is different from malaria. In a sense, in malaria, you spray the whole wall of the house. In the case of Addis, you need to spray only 1.5 meters from the ground, because Addis are weak flyers. Now, in the past, in 60s and 70s, this method was successfully used in South America to eliminate Addis as part of the yellow fever campaign. But after that campaign was over and things relaxed, the population bounced back. So we really need a high coverage and a very good standard. And we are really waiting for one randomized control study currently ongoing in Mexico to come up with their results. Currently, there is a recommendation with a moderate level of evidence, because now Cochrane really wants good designed studies. So we really are hoping for this study to be completed in Mexico, hopefully this year. Now, spray spraying, as you know, is a very popular method for Aedes control, and they have done both indoor and outdoor. For indoor, there is clear entomological impact proven, but evidence on transmission reduction is still weak. So it is a low to moderate evidence. And for outdoor, frankly, there is very weak evidence. And in fact, it is not even being graded. So spray spraying is good to control the vector. And this is why WHO recommendation is to use it only for an emergency. It has a weak recommendation for indoor spray spraying, but for outdoor, there is really not much of evidence. Next one. Next slide shows you the other methods, basically the larviciding, the source reduction with community support. There is a very good study, a randomized control study, which was done in South America. And this has been very well published in British Medical Journal. And there is a moderate level of evidence, but it is a question of a whole locality. The community is getting fully involved to make sure that there is no breeding in and around their homes. So this is a good study. We are waiting for more grading to be done in June. Then, of course, there are several larvicide methods, but there is really no good randomized study. But larval controls are good to suppress the vector population. So there is a good recommendation for it, but we still need evidence on transmission reduction, which is rather weak. So in the case of Aedes control, one of the unique things is we really need to target both adult and the larvae as part of an integrated control. Next one, please. The other tools which are currently under review is, of course, treated nets. There is very weak evidence, but we encourage people who have dengue and who are in hospital or at home sleeping during the day to use a net. And at the same time, anyone who has the habit of sleeping during the day, it is advisable to use a bed net. So it's really a conditional recommendation. We are still grading it. Treated curtains have shown some potential again, but there is very little evidence on transmission reduction. There is definitely evidence on entomologically. And repellents, as you know, is a personal protection, which is always recommended. And it is a good practice statement. We don't have large-scale study evidence. Next one. So basically for Aedes control, as I said, we really need strong evidence of integrated control involving both adult and the larval stages. And we have some studies going on currently in Malaysia and Brazil, and some of these papers highlight that. And we really hope that some of these studies will come to WCAG with clear evidence to show that a mixture of measures targeting adult and larvae can successfully control not only the Aedes population, but transmission of diseases like dengue and other arboviral diseases. Next one, please. I think that's my last one. Yeah, thank you very much for giving me the opportunity. I'm happy to answer any question, and my email is here. If you feel to write to me, you are most welcome. Thank you.
Thank you, Rahman, and for keeping to time. I like your tie. It's very good. We continue for all the other information you've given us, taking us through the tools, the broad spectrum approach through the tools. But we'll keep all the questions and answers until we hear the third presentation. So if Florence is ready, Rahman, please stay on.
Yeah.
Yes,
Okay.
I'm online.
Hi.
Hello.
Hi, Florence. How are you? Good
Hi.
afternoon, wherever you are.
I'm
Yeah.
okay, thank you.
The floor is yours.
Thank you so much. So you can see me and hear me well. So I will present you what TDR is doing regarding the prevention and control of vector-borne diseases, and in particular of Aedes-borne diseases. So I will start my presentation. Please, next one, please. Yeah, to just explain where we are within the activities. We are within the WHO response for vector control that was approved by the member states in 2017. And as you can see, we are working on the pillar 1, 4, and 1 of the foundation. Pillar 1 is about strengthening the intrasectoral actions and collaborations. Pillar 4 is scaling up and testing tools and approaches. And the foundation is to support increased basic and applied research and innovation. So next slide, please. I know most of you are maybe familiar with this kind of scheme, but they are representing well the factors that are influencing the transmission of vector-borne diseases. And as you can see, they're very numerous. Some of them are only abiotic, so like the climatic factors, temperature, rainfall, wind, etc. And they are affecting the vectors in so many different ways that it is not straightforward to say temperature will do that or will have that impact. It's much more complicated than that. And other factors are linked to other sectors, which are environmental, agriculture sector, sometimes it's social determinants, and not just health system related determinant. And again, this increase the complexity of tackling those diseases. So next slide, please. One of the approach that we were looking at for the past few years was the multi-sectoral approach, how to involve other sectors and health into the prevention and control of vector-borne diseases. And so as you see in part of the slide, the different sectors are moving apart, and on the right of the slide, we try to put them together around the table to better understand what is the impact of some of them or each of them, and how they can work together to prevent and control the disease. And the sectors are broad because it's not just about water and sanitation or housing, which are the more known, but the energy sector, for example, through the building of dams, can have a very big impact on disease transmission. Next slide, please. So we are working on multi-sector approach since a few years now. We started with commissioning reviews, organizing workshops and events that were leading us to develop the theoretical framework on multi-sector approach, because we realized that some theoretical basic approach was missing. This theoretical framework was released in 2020 and then tested through several case studies in collaboration with the Water and Sanitation Department in WHO, the NTD department, of course, and also the Global Malaria Program. And we supported 4 case studies. I exemplify 3 of them in these small images. And in the next slide, I will just give you one example. Yes, we are also supporting some capacity building around MSA with the development of a massive online open course. We already have 1 module online, and then we are planning to have another 5 modules to be released until mid of this year. Next slide, please. Yes, just one example of multi-sectoral approach, which has been very successful. This is the example in Ecuador. The research team in Ecuador, they work with the water and sanitation sector, they work with the environmental sectors and in education sector in the city of Manta. And they have developed an application through this global, I would say, approach and research project, which is called Pablito. And yesterday, we just got the very good news that this application was recommended by the Ministry of Health of Ecuador to be deployed at the largest scale in the country. This application is used by anybody, but also by children, to geographically mention the breeding sites of mosquitoes. So when they find, there is a very nice video that I put in the link in my slide. When the people are finding breeding sites of mosquitoes, they can just send a note in the application. This note is collected by the Vector Control Agency, and then they can send people to eliminate the breeding site. And this approach in the area that was under study in the city of Manta was so successful that during the epidemic last year, this area did not report any cases of dengue. As you see in the small graph, in 22, 21, 2020, dengue cases were reported regularly. And in 23, they had no dengue cases. And so I think there is a very, very strong community participation based on education and also some technological improvement that can really help us to protect and prevent those diseases. So next slide, please. I think my second step is about the sterile insect technology that we are currently testing in the Pacific countries. So I saw that Rahman explained all about the testing of the SIT. So what we are doing is we developed the guidance document. Now we support the testing of SIT, and we are also using this approach to enhance vector surveillance, building capacity, and we hope it will move through new recommendation and policy. Next slide, please. So that was the plan for testing the sterile insect technology. We started in 2019, and then we are going for the moment until the end of 25. So we start with developing the guidance document through groups of experts, and we apply the quality norm and standards of WHO for developing guidelines for this document, which is building guideline development groups and expert review groups. So that was not proposed as a guideline because we are not the WHO department, but nevertheless, we follow the rules. And then we open a call to select the consortium to test the SIT. We prepare for the SIT testing, and the field trial I've started last year with the first entomological collections. And we also engaged with the WHO Vector Control Advisory Group in September last year to present this plan and to have recommendation from the VCAG on how best to improve this testing. Next slide, please. So just I was presenting the guidance framework for testing the technology, but we can move quick on that one. Next slide, please. Yeah, so this is where we will be doing the testing. So I show you the 3 sites in which the release of the sterile mosquito will start in July this year. So one of the sites is in Tahiti main island. This is a randomized control trial, but the houses which are selected randomly, as well as within the epidemiological survey, are not in the same area, because it's impossible to have neighboring, I would say, site for releasing sterile mosquito and making the control. So there is a buffer zone, which has been recommended by VCAG, of 3 kilometers between the testing site in red and the control site in yellow. The second site is a small island called Tetiaroa. There will be no control in this island. There will be the control in another one, because it's too small. And I have to say that this site of Tetiaroa has been put into the SIT because it's fully funded by a private touristic organization which want to get rid of the mosquito in the island, and they decided to pay for it. So that was a good idea, I mean, that we could do. And then the other one is the site of Aitutaki in the Cook Island. And this one will start the release in December. So for the moment, we have not the real graphic of the planning of the control and the intervention. Next slide, please. So the intervention will move in what we call an expanding operational block in 4 phases. So the release will develop along a bi-directional front. This is a well-recognized technology for testing SIT. Stage 1, there will be the collection of baseline data. Stage 2, they will start with reducing the vector population through breeding elimination, because SIT is working much better if we lower down the mosquito population. Stage 3 will be the release of the SIT male, and stage 4 will be, stage 4 will happen if we go to population suppression or low disease prevalence. So next slide, please. Next slide. Okay, so this is the PAC SIT project timelines. So they have already started with a communication activity. They have a communication plan, which include the communities, the stakeholders. They already strongly engage on that. And I think I have a few slides on that. And then, as you see, there will be the different steps of the testing. Next slide, please. Show to you too quickly the facilities for mosquito production. I have to say that this project is supported by CDC, which is part or funding partner on this activity. And but not only, since the facilities are paid by the government of French Polynesia, and the technician working in the facilities are also paid by the local government. Next slide, please. So this is counting and sex sorting of mosquitoes. So they have the relevant technology for doing all those steps. Next slide, please. Next slide, irradiation and release of mosquitoes. So release will be done through buckets that will be open in the different sites. So there will be weekly ground releases of sterile male with batches of 150 to 300 sterile adult male. And the initial ratio is 10 sterile male for 1 wild male. So there will be mark release recapture to estimate the densities of the mosquitoes before the release. The testing will be implemented for a period of 12 months. And this ratio may be adjusted as we move on with mark release recapture to control the densities of the mosquitoes. Next slide, please. This is concomitant with an epidemiological survey. So this epidemiological survey will be on serology, because dengue cases, as you know, are not a very good indicator, since most of the cases are asymptomatic. So it's very difficult to compare situation with cases. And then they will go through seroprevalence, and they will also measure the exposition to bites of Aedes mosquitoes through serological tests. The team working in French Polynesia is working with a testing to, they have a serological test measuring the number of bites, or it's not exactly the number of bites, but the quantity of bites taken by the people. So this is a direct measure of biting. So the collection of epidemiological data will start in May this year, and then they will go on at +6, +12, +18 months to see if the seroprevalence is changing as the sterile insect technology is implemented. And as I was saying, the data collected will be the serological status for arboviral diseases, detection through IgG for dengue, and we are also planning to have PCR for people who are reporting fevers, and serological test status for IgG and T-saliva of mosquitoes, and of course the entomological data and the social data on individuals, like housing, environment, living condition, habits, professional occupations, and so on. Next slide, please.
Florence, you have 2 minutes.
Yeah, I'm also finished. So I'm showing you the PICO question. Next slide, please. I think the community engagement. So they already started engaging with school, with children, with meeting with the communities, distribution of flyers, social media. Next slide, please. And they also started engaging with the stakeholders. So they have official visit of the mosquitoes facilities by the political people from the government of French Polynesia, the parliament. They have a meeting with stakeholders in the Cook Island, representative of the communities, and so on. So there is a very, very great welcome from both communities and stakeholders for the technology. They're very, very happy to be part of this testing. And next slide, please. I think I'm almost on the last one. Yes, we have a SIT, no, not exactly. We had an SIT training workshop in Tahiti last year. Next slide, please. To increase capacity building. Next slide. The objective of the workshop is quite easy. Yes, during the presentation of the project at the Vector Control Advisory Group, we have several important recommendations that will be taken on board. The first one was the statistical plan for including power analysis for ability to detect an epidemiological impact was not presented because at that time we didn't have the serological baseline data, which is really needed to determine the sample size and the type of analysis that will be performed. So as they will have the baseline data on serology, the statistical analysis plan will be developed. Then the WCAG recommends to consider the movement of people. This recommendation will be taken on board also through inclusion and exclusion criteria based on the people movement, in particular between the intervention and control area. And then the WCAG recommends the quantifying the impact of dengue outbreak on the study outcome, and the potential impact of local responses on fogging, for example. And well, dengue data are reported by the health system in Tahiti, which is quite strong. So these data will be used, and then fogging is not implemented even during an outbreak in Tahiti. They are using mainly source reduction, and they will do the same source reduction in intervention and control area. And I think that was my last slide. Thank you very much for your attention. And I will be welcoming questions. Thank you.
Thank you, Florence, and thank you for telling us all the TDR is doing and the multi-sector approach. You went over by 1 minute, but your lovely voice has taken care of that. Please stay on until Diana finishes her presentation. Then we take all the questions and answers. On my side, it's lovely Diana, who will be giving a talk on the Global Arbovirus Initiative.
Thank you very much.
Thank you. It's a pleasure.
And well, my slides are there. So let me introduce myself. I am Diana Rojas. I'm the team lead of arboviruses, chikungunya, and Zika in the Epidemic and Pandemic Preparedness and Prevention Department in the Health Emergency Program at WHO. And I co-lead with Raman Velayudan, who just presented the Global Arbovirus Initiative, which is a pandemic preparedness plan to tackle mosquito-borne viruses with epidemic and pandemic potential. So let me start thanking the I Secretariat for the invitation to this amazing meeting. I have been taking notes in all the efforts that you have taken in the last few years, and start thinking in the huge challenges that are coming up with the new vaccines that are coming for other arboviruses, and so much to learn from all of you. So we have almost 4 billion people that are currently at risk for Aedes aegypti-borne infections. And this number is estimated to increase by 1 billion by 2050 due to the effects of climate change. But as Florence said, climate change is not the only responsible for the increasing numbers of Aedes-borne diseases in the different areas. Climate change has an impact because it can increase rainfall, temperatures. However, there are other drivers of transmission of these diseases that take a very important role, and most of them are social factors, unplanned urbanization, population growth, and other factors related to the globalization. So it's a complex issue, and it requires a multi-sectorial approach. Remember that health and disease in humans is the effect of climate change in humankind. So climate change is the disease in the planet, but we are going to start seeing more diseases that is the related impact in humans. So we are currently in a grade 3 emergency for dengue, given that last year more than 5.5 million cases were reported worldwide, and we have the 6 regional offices reporting cases. And that led, we were also with the El Niño phenomenon ongoing, and we anticipated that this year was going to be a year with very high transmission. And I think we were right, because in the last 2 months and a half, we have had reported 1.9 million cases of dengue. So far, there has been a very active transmission season in Brazil and in the South part, in South America in general. Next slide, please. So the Global Arbovirus Initiative The concept of the initiative came up in 2019, which was the year back then with the higher number of cases of dengue cases and the need of having an integrated approach for these Aedes aegypti-borne diseases. So as was mentioned before, they share the same mosquito, and for yellow fever, it would be the urban mosquito of yellow fever. And also they require the same challenges. So clinically, they look very similar in the first few days. They co-circulate in the same areas because they have the same mosquito. So there are 6 pillars that are in part of this arbovirus initiative that I will go one by one and also with all the updates. Next slide, please. So this arbovirus initiative is under the umbrella of the WHO Triple Billion Goals. And the Global Vector Control Response Initiative, the Protected Tropical Diseases Roadmap, and of course is complementary to the Eliminate Yellow Fever epidemics, mostly to prevent and to create resilient cities to avoid or prevent urban transmission of yellow fever. Next slide. We know we work better together and we all have our strengths, so that's why we complement each other. So the first pillar is about monitoring risk and anticipation. So what we prioritized since 2022 was to develop a global risk monitoring framework for arboviruses using the One Health approach to build a baseline epidemiological information and environmental and entomological information to have a global view of what's going on. And once we establish the baseline, then we are able to forecast and model potential epidemic and pandemic scenarios. With arboviruses, we don't have the risk of respiratory virus of causing very large pandemics. However, the previous public health emergency of international concern before COVID was due to Zika virus. So we can have public health emergencies of international concern. Next slide, please. So some of the progress, so we have been reviewing the drivers of urban transmission of arboviruses. We have been mapping the risk of the vulnerable areas of arboviruses for transmission, emergence, or potential reemergence. Strengthening the surveillance at all levels. So we have very heterogeneous transmission of dengue and arboviruses in general. And also the collection of the data is very heterogeneous among the different regions. So we have been working in strengthening the surveillance system in the local, national, regional level, so we can get the data flowing. So we are currently establishing a baseline data for arbovirus incidence. We are working on an arbovirus dashboard that hopefully will be ready soon. We are working on implementing the One Health approach for arboviral diseases. The regions have been sharing experiences. So PAHO, for example, is very strong in surveillance systems and in their dashboards. So they have been sharing their experience with other regions. And now we have CRO and the Western Pacific region, the Eastern Mediterranean, and also the African region building and strengthening their surveillance systems. And with TDR, we have been collaborating with early warning systems for climate-sensitive diseases such as dengue and the early warning system. Then we have, and what we are thinking is that eWorld CSD is the analytical tool for the dashboard, because it's not just sending the data, but also how to bring the tools to analyze the information to the local levels. So the analysis and the early warning can be done in the municipality or in the city where the transmission is occurring, instead of having to wait until it goes to the region, right? Next slide, please. So this is a screenshot of the global risk map for dengue virus. Raki, the link? No, it's, okay, thank you. So I took a screenshot in case that the link was going to be funny. Thank you. So we have the mapping of risks of spillovers of several pathogens. So if you could go to where dengue and click on dengue in the right, yes. So this was a work done with several of the partners of the Global Arbovirus Initiative. It was led by the London School of Hygiene and Tropical Medicine, but we included Imperial College of London, Hopkins, when all the big modeling groups that have been working for years in risk mapping. So for dengue, there are several risk mapping that have been done. The last one was published in 2016, but since then, things have changed. So they updated these risk maps with it's a suitability map that includes temperature, precipitation, vegetation, predicted suitability for TCG size, algal pitches, and so on. And also includes we adjusted the model with some surveillance variables, such as how close is the next hospital and so on. So if you could zoom in the African region. Yes, perfect. Yes, you can zoom in a little bit more. So what you have here is a risk map that has a 1 kilometer by 1 kilometer information that you can check. Well, if you have a yellow fever transmission near of any of these areas that is red, it means that there is a probability that you might have urban yellow fever. So we use it for dengue, but the closest proxy for urban transmission that yellow fever can have is dengue transmission, at least in South America. Well, you will need to see if that applies to the African region. We are currently validating this map, and if anyone wants to look a little bit more into it, please let me know. This is a draft, but happy to look into it. Can we go back to the presentation, please? We have one also for Zika and chikungunya. However, the teams that were working with us, they told us, well, they look basically the same, like the dengue, Zika, and chikungunya look very similar. So, well, but at least we were able to update the other ones. I already mentioned the dengue 3 emergency, so let's go to the next slide. And we have also been working in a global dashboard for dengue and other arboviruses. We currently have the data from the Americas, where the transmission season is very high, but now we are starting to gather data from Southeast Asia and also from the Western Pacific. And with the grade 3 emergency, we hopefully start getting also real-time data from the African region, which reported several outbreaks last year. Next slide, please. The second pillar is about reducing risk, reducing epidemic risk. So we have several priority actions. It's about strengthening early detection, increasing capacities to perform epidemiological investigations, improve response to arbovirus outbreaks. And here also we included increasing population protection through yellow fever vaccination in high-risk areas through the implementation of the I strategy. Next slide, please. So in this specific pillar, we are currently updating the integrated arbovirus clinical guidance, and one of the integrated products with the I strategy. We are updating for dengue, Zika, chikungunya, and yellow fever because clinically they look very similar, and it just made sense to it in an integrated way. We are updating the case definition for dengue, Zika, and chikungunya. We have been strengthening laboratory networks. Currently, we have molecular diagnostic capacities after the COVID-19 pandemic that allow us to do more molecular testing for arboviruses. We have been updating also the outbreak toolkits, as it was mentioned by Georgie, evaluating kits for ELISA and molecular diagnosis of arboviruses, because we all share the same challenges of cross-reactivity among the different flaviviruses. And we have also updating a manual for detection and response to arbovirus outbreaks. Next slide, please. The third pillar is on strengthening vector control. But to be able to strengthen vector control, we need to enhance environmental and vector surveillance. To be able to control the vector, we need to understand where the mosquito is breeding and where it's located, so the vector control is targeting exactly the areas that we want to target. Then strengthening cross-sectorial vector control, as Raman and Florence already mentioned. and increasing preparedness in urban and densely populated areas, which is, well, all of these pillars will help to prevent urbanization of yellow fever. Next slide. So as Raman mentioned, there is a dengue vector control guidance and that is currently being reviewed, and the recommendations are expected to come up by June this year. We have been working on operational manual for novel vector control tools, the collaboration with WASH, the global insecticide resistant monitoring, and online training courses have been also developed by Open WHO, and we have been also working together with the International Health Regulation on border health in vector control. Next slide, please. I'm scared of the hammer, that's why I'm running. Pillar 4 is about preventing and preparing for pandemics or for public health emergencies of international concern. So we have 3 priority actions. One is enhancing the global coordination among the different stakeholders, and if there is something that I learned today from have been learning this meeting, is the importance to coordinate with partners and with the different stakeholders. The second one is strengthening the global surveillance mechanisms that will allow a rapid response, and we have discussed this: strengthen community engagement and resilience. So outbreaks start in communities and they spread in communities, so we need to engage and the communities and help them to be more resilient. Next slide, please. So for this pillar, we have been working on preparedness and resilience for emerging threats. The chapter 2 is going to be on arboviruses. The first chapter was for respiratory viruses, and now we have the challenge of using these tools or methodology for arboviruses. Risk communication, as I mentioned, increasing reporting and increasing awareness. Next slide, please. In Pillar 5, it's about enhancing innovation and new approaches. So developing integrated public health research agenda for Addis-borne arboviruses, supporting the development of innovative countermeasures for arboviruses, such as vaccines, potential viral therapeutics, diagnostic tools, and vector control tools. And the third one is developing new tools and approaches for public health preparedness and response. Next slide, please. And then for this specific pillar, we currently updated the public health research agenda priorities for Zika. We have been working in the target product profiles for the chikungunya vaccines, but now we need to discuss a little bit further with the immunization vaccines and biological department to have a strategic advisory group on chikungunya vaccines and come up with recommendations. The vaccine has been approved by the FDA, and some countries are thinking in introducing this vaccine. We have been also partnering with the Drugs for Neglected Disease Initiative in testing therapeutics for dengue and other arboviruses, and they are also running some seroprevalence surveys in Africa to understand a little bit better the real burden of arboviruses in the African region. We have been working with FIND, which is another of our partners, in developing new diagnostic tools for arboviruses, new vector control tools, as it was explained by Raman and Florence. And now the 2 bossy words after the pandemic: one, genomic surveillance for arboviruses, right? So we are trying to assess which are the main needs on genomic surveillance for arboviruses, which are the uses for genomic surveillance for arboviruses, to come up with the specific recommendations. And wastewater surveillance has also been mentioned for arboviruses. Zika virus is found in wastewater surveillance, which is great because most of the infections are completely asymptomatic, and we would like to prevent the complications, which are Zika congenital syndrome and also Guillain-Barré syndrome. So a good way of monitoring Zika virus will be wastewater surveillance, and the partners that are interested in wastewater surveillance have been looking for other potential arboviruses that can be found there. Next slide, and the last but not least is Pillar 6, which is building a coalition of partners. So we are currently strengthening partnerships among the different stakeholders, enhancing communication with stakeholders, and building new partnerships. In summary, the Global Arbovirus Initiative, next slide, is complementary to the eye strategy, and the progress on its implementation will benefit urban preparedness for yellow fever. A stronger surveillance for other Aedes-borne arboviruses in urban settings will improve early detection of yellow fever in urban settings. Environmental and entomological surveillance are key to guide vector control in urban settings. They have same vector, same tools. We need to build more resilient cities and communities for climate-sensitive diseases. We need to keep advancing the public health research agenda to address the common challenges and keep strengthening our partnerships to achieve our goals. Next slide. Oh, and I don't want to scare you, but these are all the other arboviruses that are circulating and that we are keeping an eye on. So depending on the region, we have Rift Valley fever, Kenyan Congo, West Nile, and many more. So we are also keeping an eye on these other arboviruses. Last slide. And I want to thank all of our partners that have been supporting the Global Arbovirus Initiative, especially the US CDC, the German Development Fund, and TDR, and all the other partners, the regional offices, the member states, and all of you, that if at some point you see an arbovirus case, you will be part of this arbovirus initiative trying to prevent and control. Thank you very much, and I hope I'm on time.
Ghana, I almost said Ghana Ross, is generation gap. So, I want to thank the three of you, Raman, Lawrence, for at least showing all the enormity of the pollen that we have. But more importantly, that through multi-sectoral collaboration, we can find a solution to these problems. So the three presentations are open for questions and answers. I hope somebody's going to let us know online who has answers, questions. But from here, we start from here. Are there people who have questions, comments? Yes, sir.
Okay. Thank you very much. Well, I will make some comments, and I want to hear from Diana.
After the question and answer.
Well, I will talk about dengue. I know that it's not the subject here, but I will talk about dengue. And now in Brazil, we have our worst dengue outbreak of our history, and we incorporate the dengue vaccine in our national immunization program. Our NITAG followed the SAGE recommendation, right? And considering our epidemiological situation and the public and political pressure, we incorporated this vaccine. And I want to comment that for me, as director of National Immunization Program of Brazil, the SAGE recommendation was not good. Actually, was a bad recommendation. Why it was a bad recommendation? Because we are talking about a very expensive vaccine. The production is not sufficient to provide us. It's we bought like 6 million doses. It's nothing for Brazil, and there are some lack and some gaps of knowledge in this vaccine. And now we are investigating safety side of anaphylaxis. We had like 20 cases of anaphylaxis after 600,000 doses. It's very high, a very high rate of cases considering the number of doses. So I need to say that I think that SAGE recommendation was not good, and I want to hear from you. What do you think about it? About what happened in Brazil? About our experience with the vaccine? Thank you very much.
I think let's see.
Chair,
I think another question.
my apologies. We will need to call time soon because we're nearly 30 minutes late. So just flagging. Thank you.
sorry. One more question. I think we take just these two and we go to the next one, and then she will answer, and the others too. Yeah, please go ahead.
Thank you so much. Okay. Mine is, thank you for the nice presentation on the Global Arbovirus Initiative. As you can see from the WHO report, Ethiopia has been experiencing a vast outbreak on dengue in 2023 since April. Till now, we have almost more than 25,000 cases in 5 subnational. So following this, but we don't have organized vector control program for arboviruses. Our vector control program is mainly focused on malaria, so that multiple experts in the country are aware of on the Anopheles mosquito, but on the Addis, we lack expertise, and even there are no specific recommendations on the vector control approaches for the Addis. So we have been using environmental management and larvicidal chemicals for the districts with the outbreak, but it wasn't effective for a while. It will be decreased, and then the resurgence is repeatedly occurring in the same district. So is there any specific vector control program or a specific approach based on the vector behavior of the arboviruses, especially on the utilization of indoor residual spray and the larvicidal chemicals? Besides, as we all know, there is no specific treatment, but we have been facing severe dengue cases. Even there were deaths in some districts. So on the treatment guideline, is there any specific treatment or approach recommended currently for the severe dengue in the Africa? Thank you so much.
Thank you very much. We're going to limit the questions because time is running out. Unfortunately, Sage is not here, but Diana is here. So these are the 2 questions.
Well, I will try to reply to your question, and please, Raman, feel free to jump in as you are part or attend the SAGE meetings on the dengue vaccine. So this vaccine was recommended for high transmission settings, which is a bit vague, because what does it mean to have a high transmission setting? So the ideal situation will be to have seroprevalence surveys where it's a real high transmission setting, and introduce this vaccine in the age where you have most of the infections. There are some gaps of knowledge, that is for sure, and the clinical trials for these vaccines were run during the pandemic, so the numbers are very low. That's why it's also recommended to do a close surveillance of severe adverse events that you are doing, and also a phase 4 trial where you introduce in an organized way in the community to be able to evaluate the effectiveness in the population. I will bring your comments to SAGE and our IVB members, and we can keep the discussion afterwards. And for the Ethiopia entomological recommendations, I will give the word to Raman. Raman, over to you.
Thank you. Frankly, basically, one thing which I really want to say is that is how I began. This base of the second floor is
Rama, we can hear you.
Can you hear me now?
Yes.
Okay. So basically, the situation in Ethiopia demands a concerted effort. We really need to keep going with vector control and reduce the population and enhance vector surveillance, which is basically to monitor the density so that this situation does not arise as we move forward. As I began my talk, I told you that most of these tools are not fully proven to be effective. And this is one of the challenges we are facing. And we hope that with Wolbachia and other tools coming through, we will be having better tools. This is one of the weaknesses in dengue control. We do not have a sustainable tool like malaria. In malaria, you have bed nets, you can spray the house, but in dengue, it is very much locally adapted tools. We have had certain level of success in few countries, but it is very much country driven and based on what communities can cooperate and accept. So we really need to continue with vector controls which are ongoing, and mainly focusing on both the adult and the larvae, and to make sure that whatever control operations you do is monitored by vector surveillance so that we continuously reduce the population. So this is what I can say. We will come up with recommendations on newer tools in the next 6 months, but they are not a full-scale answer to this. And to go back on the question of the vaccines, again, we must remember that I agree the SAGE recommendation was a very cautious one, taking into account what happened with the first vaccine of Sanofi. So many of you may be aware that Sanofi has actually stopped production of that vaccine. So we are left with only one vaccine at the moment. And we really look forward to other vaccine candidates in dengue, which includes the Brazilian vaccine, the Butantan and others, to come through the pipeline and may have a better option and better efficacy against all 4 serotypes. Now, you know, there is a lack of data on Q dengue for dengue 3 and 4. And so those things are also being looked at by the manufacturer, and we hope we will get better data soon. I'll stop there. Thank you.
Thank you. Florence, do you have anything to add on?
No, I think my colleagues have said all. I don't have anything to add. I just I would say confirm that we need innovative tools, SIT, Wolbachia, beta traps, but I would say that whatever the tool, we must have collaboration with other sectors and with communities, because technology is not just what we need. I mean, in Ecuador, we had a very, very good example that what has really make a difference was the community involvement into the fight. If the people are not fighting against the mosquito inside the house, I think it's going to be very, very difficult to do it, even with the most updated technology. So maybe that could be my last word. Thank you.
Yeah, thank you very much, our 3 presenters, Raman, Diana, and Florence. Florence, for the work you do, I'm glad I'm not a mosquito. I will now hand over to Mary to facilitate the next panel discussion.
Thank you. Can I kindly ask anyone to come? So we have a panel discussion to wrap up this topic of urban yellow fever, and hopefully to get some clarity for the steps forwards. And I kindly ask Annie Mange to come. She's one of our 3 panelists. If she can come and sit. Thank you, Diana. Tu peux venir comme ça. So we have, just to quickly introduce, we have a few questions for Erin Staples, and you all know Erin Staples, who's here as the chair of the Eye Risk Analysis Working Group. There's Maury Keita, regional advisor on infectious hazards preparedness, and Annie Mange. We wanted a country perspective. Annie Mange is a medical epidemiologist, and she's head of the surveillance of the Vaccine Preventable Disease Unit at the EPI program of Cameroon. And so we're all worried about, we have just a few slides, but this is just some background, some visual support, let's say, for the discussion. So we are worried about this urban yellow fever. That's why we had all these sessions, including on vector control. Urbanization is increasing. We have major immunity gaps in urban centers, and that was again found during the immunity gap analysis done in Cameroon in December. And we regularly have cases from urban centers or peripheral urban areas. And in Africa in 2023, we had a case in Kinshasa, a case in Cocody, which is really a neighborhood of Abidjan. And we had 7 cases in Douala, urban Douala, and this is why we have Annie Mange here, who will talk about that. So this is just a kind of a list that was done by Dr. Kuno on all the urban outbreaks. There were many outbreaks in the past, and you'll see that experts don't all agree on the criteria to define what is urban yellow fever outbreak, but that's not really what we'll discuss now. But it's just to show that we've had urban outbreaks in the past. They're, of course, much less frequent than the rural ones. And maybe that's why we've been neglecting this risk and all the efforts to prepare. And so maybe I'll start with the first question for Erin, which it's kind of a 2 parts. So first, Erin, if you could tell us more about urban transmission, and also should we be worried about urban yellow fever transmission, and where would be the biggest threat? And keeping in mind also what Katie from Imperial College told us yesterday, that of the risk of yellow fever epidemic in Djibouti city, which today is not considered a high-risk country for yellow fever. So over to you, Erin, for that first question.
Sure, thank you. I was just writing notes so I stay on task. So in terms of more about urban transmission, I think one of the things I like to do is just kind of review virus transmission and why do we fear and what is the timelines for seeing a large urban outbreak. Then I like to put up this slide of basically how urban transmission happens, where there's incubation period in a human. So after they're initially bitten, they will have an incubation period before they develop symptoms. Shortly before they develop symptoms, they actually have a period of viremia where a mosquito can feed on them even before they know they have symptoms and acquire the virus. The virus then has to, in a naive mosquito, go through an extrinsic incubation period. So the period for incubation in a human, which is the intrinsic incubation period, is a median of 4 days. In a mosquito at 25 Celsius, it's about 10 days or 9 days. So in the course of about 14 to 15 days, you can go from just one individual being introduced into a population that has viremia, a local mosquito biting someone, and then being able to transmit that to more people. And it's not just a one-to-one relationship. It's usually, several other people will be infected. If you can go to the next slide. This was mentioned by Mark earlier, and I've talked to Pedro a little bit about this, but this is a visual. I'm a very visual learner, but this is the location and the approximate illness onset for the outbreak that was happening, in one of the areas of Asunción, Paraguay. And there were a total of 9 cases, thankfully, due to quick reactions and vaccinations and also changes in the weather. But you can see that the index case is shown in yellow. It happened on the 21st of January. And then the next case, which is almost on top of it, the illness onset was February 8th. That was 1 incubation period. The cases all to the right of that in red, those were all part of that first incubation period. By the time the outbreak was being recognized, they already got to the 2nd incubation period. So these things can amplify relatively, rapidly, and thankfully, again, due to quick reactions with vaccination and a change in the weather, which happens in Paraguay. But one of the reasons that we think this was urban, despite not finding, as we say, the smoking mosquito, the mosquito that was positive with the virus, was the demographics. These were housewives and students. They had not gone to an area where the virus would have been considered. The last person of the 9 cases was actually a gasoline station attendant. So it was probably exposed by someone coming through that was infected. So that's always it's not a very pleasant visual, but it's a good visual to understand how quickly things can expand if they're not recognized. So that's why I think, understanding a little bit more about the urban transmission. The only other thing to note, maybe Marie-Ève on the next slide, would be this is just another slide reinforcing in Angola, we knew this in Luanda, that it was young children that were being infected and housewives. It was not a disease of older adult men or men that were going out. This was happening in urban areas. That's another good indication of urban transmission. On the next slide, what we actually pick up by surveillance usually, though, is what the top of that pyramid, those cases, those severe cases. So that's only a very small proportion of the cases. And if you go to the next slide, for every severe case, you have 9 mild infections, so febrile illnesses, which are probably, depending on where you live, called malaria or dengue or something else. But thinking about that, you actually have 21 infections for every death. 5 of those 9 cases in Paraguay died. So if you use that, we are actually talking about 100 plus people that were infected probably in that area. Those infections, even if they're not symptomatic, can be picked up by a mosquito, and you can get rapid expansion of the disease even before you know it. So these are things that make us, people involved with yellow fever have sleepless nights when we think about urban transmission and what could happen. And it was seen very well, and I'm sure Prof. Tamari can comment, in Nigeria about the rapid expansions and large amounts of disease. So to get to the second point, should we be worried about urban transmission? The answer is yes. I think we need to be diligent about it. The question of where, personally, I think it's going to be in urban centers that sit close to or in areas where we consider there to be a risk of yellow fever. Those are going to be the first ones if there's inadequate vaccination. So ensuring that there's adequate vaccination in urban centers that are adjacent to or lying in it, I think I would go to those locations, because it really is people moving from one location to another. That is the main way that yellow fever is spread, more than mosquitoes. The mosquitoes have spread many other diseases. Ensuring good population immunity in large urban centers is the best way to potentially prevent these urban outbreaks that we do have concern about. So thanks for those questions.
Thank you, Erin. And I'll move on to Annie. So I kindly ask you, for those who don't understand French, to put your earpiece. So I'll say the question in English et ensuite en français, je dirai la question. So there were, this year in 2023, 7 cases, yellow fever cases that were confirmed in Douala. And the question is how have the health authorities been handling this, and also whether there were any challenges that you faced, and any specific support you would need. Donc la question c'est, donc il y a eu 7 cas de fièvre jaune qui ont été confirmés à Douala en 2023. Comment est-ce que les autorités sanitaires ont géré ça? Est-ce qu'il y a eu des défis particuliers, des problèmes? Et aussi quel soutien, de quel type de soutien auriez-vous besoin pour gérer ce type de situation?
Merci de me passer la parole. Merci de me passer la parole. Concernant les épidémies de fièvre jaune au Cameroun, particulièrement dans la grande ville de Douala, où il y a où il y a une population qui est quand même assez dense. Le principal défi que nous avons, c'est avoir des investigations de qualité et des investigations à temps pour pouvoir mener des actions spécifiques pour pouvoir lutter contre ces épidémies-là. Alors, ce que le gouvernement, en appui avec ses partenaires, a fait, c'est déjà mettre en place une équipe sur place et une équipe en collaboration avec le niveau central pour pouvoir mener des investigations approfondies et des investigations pluridisciplinaires avec des entomologistes. Donc, ce qui a permis d'avoir les résultats que vous avez au niveau de l'écran, où nous avons retrouvé Addis un peu partout dans ces différents districts-là. Et actuellement, nous avons commencé à voir dans quelle mesure initier la lutte antivectorielle. Il y a, malheureusement, on n'a pas pu vous présenter ce qui a été fait dans la semaine dernière concernant cette lutte antivectorielle-là. Donc, là, en collaboration, bien sûr, avec le programme PALU, qui est mieux avancé par rapport à cette lutte antivectorielle-là. Donc, voilà ce que je pourrais dire. Merci.
Merci, Annie. We have a few minutes, so I will go to Maury for the next question, which is a general one. How can we support the development of resilient urban centers against the threat of yellow fever outbreaks? What would be your advice for countries? We heard also from the Brazil presentation, and Aaron also mentioned this about the quick amplification. So we know that we must react differently when we have a case in an urban context, even if we're not dealing with specifically with yellow fever transmission, but a case in an urban context requires maybe a different approach. Even in the investigation, we see how important the mapping is, which is not done when we have cases in rural areas. So having said this, how do we prepare ourselves for this? Any guidance?
Thank you so much, Marie-Ève. I would first like to point out that yellow fever outbreak preparedness is part of the general cycle of preparedness, which has three core elements: governance, capacities, and resources. Under governance, we have national policies and preparedness plan and coordination mechanism, because we know without a coordination mechanism, any preparedness plan will fail. And under capacity, you remember I mentioned, I think in my past intervention here, the risk assessment, and I said the preparedness journey start with risk assessment. So why we should assess the risk? We should assess the risk to determine the priority intervention to be put in place. And capacity should also include surveillance capacity to detect, early warning system, and health information, etc. Now, under resources, of course, we know, and maybe if I can go back to policies, even strategy is part of this governance body of the preparedness, and this should be at the national, community level, national and regional or global level. For resources are, the backbone of the preparedness. Without resources, we will not be able to do anything. Now, coming back to preparedness plan, which is under governance, in Afro region, we are accompanying countries to conduct STAR, I think last time I talked about STAR, which is strategic assessment, strategic tools for assessing risk. Then when the country assess the risk and they identify the major hazard in the country, they develop a multi-hazard plan based on this assessment. But now, usually they have a multi-hazard plan, but the multi-hazard plan is a very big and vague plan. You will not be able to do anything, maybe to mobilize resources, of course, but when it's come to be operational, you will need what we call a contingency plan. I think Brazil has presented today the contingency plan for yellow fever outbreak in urban setting. Exactly, this is what we need in the Afro region also. Most of the countries have already their multi-hazard plan, but only few countries have some specific disease plan. And under the contingency plan, normally you will have a different scenario. For example, one of the scenario will be a case in a rural area, for example, and other scenario will be a case in an urban setting. So if you don't plan properly the scenario of urban outbreak for yellow fever, you will not be ready to respond. So that's why we are encouraging countries to develop a contingency plan which will include a scenario for urban settings.
Thank you, Maury. And I wonder if Annie or Aaron, if you want to add something. Annie, si tu veux rajouter quelque chose ou...
I can always add something. Sorry. I think I just want to acknowledge that there's a lot of unknowns about urban outbreaks, and I think we have to be aware of what those are, and if we have the ability to utilize or decrease our knowledge gaps, that would be useful and allow us to be better prepared. So for instance, we know mosquitoes are not all created equal. Prof. Vasconcelos had a good report, that looked at the transmissibility of the Haemogogus, Sabrinth, and Aedes aegypti mosquitoes and found differences between those. We know there's differences between Aedes aegypti in one location and the other. That probably accounts for some of the differences we see between Africa and the frequency of urban outbreaks here versus South America. But what is it really? What is it that's driving that? Is it the low population immunity in persons? Is it just the vector? Is it competing, as brought up by Mark earlier, competing viruses that might outcompete in the mosquito or outcompete or provide cross-protective immunity in the human? I think those are all things we don't know. And the final thing we don't know is, what is the level of immunity that's necessary to stop an outbreak? The 80% that we use as a metric, it comes from knowledge about other vaccine preventable diseases. It comes from knowledge about dengue and really optimal, immunity. So it's a pretty reasonable guess that it's 80%. But what if your population immunity is 50%? Does that mean the difference of 30% is going to be infected? No, it's probably not the same kinetics. So I do think we don't have a firm understanding of, if your population immunity is this, what's your likelihood of having an urban outbreak? It's not a straight answer. It's not a correlate. So there's a lot of things that we don't know, but what we don't know often is what keeps me awake, because I can't provide an answer and I can't help someone be better prepared or know that your certainty of having an outbreak is going to be 75% in the next 5 years. No, I mean, no one can do that now. We haven't been good at it in the last centuries. So I don't think we're going to pretend to do that now, but I think being prepared and having a good detection system in place, having surveillance, having it coupled with other disease surveillance systems is the best way to recognizing it early and responding like they did in Paraguay, and Prof. Gonzalez was there. Those are the most critical things that we can do from a public health perspective, because if we respond early and we don't wait for months, unfortunately, that it took to recognize Angola, we will avoid those situations of outstripping the vaccine supply, avoid the situations that we've gotten into. What we can't avoid is the amplification of sylvatic cycles that we saw impacted Brazil per se. Again, without getting rid of every species else on the earth other than humans, which no one wants to do. There's no way that we'll ever get rid of yellow fever, but we just need to be prepared and understand what it can do.
Merci une fois de plus de me passer la parole. Bon, si je pourrais ajouter quelque chose, c'est déjà concernant l'épidémie en milieu urbain, c'est que nous allons déjà suivre les recommandations. Donc, la première qui est d'élaborer ce plan de contingence pour qu'on puisse se préparer à ces épidémies-là en milieu urbain, parce que c'est vrai que nous avons un plan de préparation et de réponse, mais nous n'avons pas vraiment mis un accent sur cette particularité-là qu'est l'épidémie en zone urbaine. Donc, et aussi, nous avons des difficultés, comme je vous ai dit, concernant la réaction prompte, c'est-à-dire pouvoir avoir une investigation de qualité, savoir si la personne qui a développé la fièvre jaune s'est déplacée. Ça, c'est vraiment encore un challenge pour nous au Cameroun d'avoir ces investigations de qualité. Et aussi le défi lié à la vaccination. Depuis le matin, on parle des vaccins. On a parlé, oui, les vaccins sont... il y a une augmentation de la productivité, mais ça reste toujours, comme nous voyons, pas vraiment encore accessible. Donc, on a ce défi-là, par exemple, dans les grandes villes, de pouvoir vacciner dans ces zones-là, surtout avec l'hésitation vaccinale que le COVID-19 est venu installer. Donc, et aussi un autre point concernant le délai de rendu des résultats du labo, qui est aussi un petit frein pour nous pour pouvoir agir promptement. Donc, en dehors de ça, nous allons continuer la sensibilisation de la communauté sur la fièvre jaune. Nous avons déjà commencé et nous allons continuer encore, surtout que nous voyons vraiment le gros risque que cette épidémie-là pourrait engendrer. Donc, voilà, merci.
Merci, Annie. I think we need to wrap up. I'll just say that there are a lot of unknowns, and even for the Douala situation, we started some more in-depth discussions, and I think that the situation there, we need to take advantage of these cases in an urban context, which does not happen that often, at least with so many cases, to really have a close monitoring and in-depth investigation to learn from that. And just to let you know that we will have very interesting, I think, discussions in the upcoming year. There's, we would like to have come up with some operational planning guideline for countries. So there's been already some work on this. So we'll take it up and make sure that we include also all our colleagues from the Americas that have a lot of experience on that. There is the entomology handbook I was speaking about on the field entomology assessment, where it is planned to include a chapter specifically on vector control for urban outbreaks. And then there is the guideline on clinical management that Diana mentioned, which is led by the Global Arboviral Initiative, which is under development. And this is also something that is very important for the urban outbreaks where we expect high caseload. So I will finish here, and I will thank all the panelists, Erin, Annie, and Marie, and give you back the floor. Thank you.
Thank you, Mary. Thank you, Mary, for smooth facilitation. And Erin, Mori, and my neighbor from Cameroon, we want to thank you for your presentation. You know, when you hear that one case of yellow fever is an outbreak, remember Erin's presentation. Yeah. That's what happens. So is that my turn to hand over to Raki to tell us what next? But before I do that, I have to officially finish my term by knocking this one. Now I understand why African leaders don't want to leave office. Thank you very much.
Okay, so thank you very much, and I would like to welcome everybody to this vaccine manufacturers meeting. My name is Kolawole Salami. I'm the medical officer with the WHO IA strategy, and I have on the table here with me the leader for the IA strategy at the WHO, Dr. Sibrelos. I also have with me the chairman of the afternoon session of today's meeting, and that is Professor Yuali Tomori. And we have also here a representative from Gavi, from Linksbridge, from WHO, from other manufacturers. We have 5 manufacturers, but unfortunately, one of the manufacturers, Institute Pasteur Dakar, could not be here with us due to very unavoidable circumstances. They are hosting the president of Senegal today, so it's impossible for them to join us. But we have a representative of 2 manufacturers, and I would like them to introduce themselves before we go to those that are online.
Yes, hello. I can start on my presentation. Yeah.
Not yet, just a quick intro. I want the colleagues to quickly introduce themselves, then we can go to the presentation.
Okay, okay.
Hi everyone, my name is Patricia Santana. I'm from Biomanguinhos. I'm the manager of market relations. Nice to hear today.
Hello, good afternoon. I am Michaela Dock and a Global Public Affairs Lead for Travel and Endemic Vaccine, representing here Sanofi. Thank you.
Thank you very much.
Yes, my name is Ekaterina Kordoban, and I'm Deputy Director of the Chumakov's Federal Scientific Center.
Is that somebody?
Hello, my name is Milan Ganguly. I'm representing Serum Institute of India, along with my colleague, Dr. Sajjad Desai and Anirudh Kote.
Thank you very much. You're welcome. We also have a representative of Sanofi here. I think if he or she could introduce.
I just presented myself.
Sorry, I guess I didn't hear. Okay, we can go online to our colleagues in Russia. Dr. Markey, go ahead and just introduce yourself.
Yes, hello, my name is Andrew Malkin. I am competent authorized person in the field of quality of Chumakov Institute Federal Scientific Center for Vaccines and Biological. Thanks.
Thank you very much.
Hello, my name is Alexandra Sinyugina from Chumakov Center. I'm a quality director and responsible for research and development division.
Thank you very much. Yeah. So I won't take too much of our time. So I know that each of the manufacturer here has a presentation to make. So since we are four, we are going to take 10 minutes per presentation, and that should give us an additional 10 minutes for the question and answer session. So I urge colleagues that are online and colleagues that are inside here to know that there are questions during the presentations, and then we'll ask at the Q&A and discussion section afterwards. So I will be starting with the presentation of the Chumakov Institute. So over to you, Dr. Markin and Alessandra.
Yes, presentation will be made by me, Ekaterina Kordoban. I'm a colleague of Andrew Malkin and Alexandra. So thank you very much. I think that 10 minutes will be enough for me just to give you a short update of our activities on the field of development of yellow fever production. So the next slide, please. Yeah, on this slide, you can see the dynamics of our yellow fever supplies, beginning from the moment when we've got the pre-qualification of WHO. So in the couple of previous years, our supply and production was about just a bit less than 15 million of doses. And in 2024, we implemented the new form of our vaccine, yellow fever vaccine in vials, which has the name of Sensavac, and we have already supplied it to a couple of countries. So next slide, please. So on the slide, you can see 4-time bone belts showing our ways to make the contribution into our joint activity of fighting against yellow fever more significant and sustainable. The upper way reflects the ongoing strengthening program for our seed lot system based upon the same WHO-sourced 17D strain to make it as much reliable and efficient as possible. The second two ways are a part of our long-term project for switching production of multi-dose vaccine from ampoules to vials. We started from the production form dedicated to the campaigns and outbreak responses, and the vial-filled 10-dose presentation, as I said previously, named Sensavac, has been, approved by WHO and is already in PQ list. So we have started it mass supplies via UNICEF since the beginning of this year. While obtaining WHO approval for the new 10-dose presentation, we started the same activities in respect of 5-dose vaccine to maintain course for strengthening the routine immunization programs. So the way below is devoted to our recent technical renovation made a couple of years ago when a new aseptic filling line was implemented, and it was implemented together with a high-speed filling line along with the 2 freeze dryers, which have been designed, constructed, and validated. Now we are at the starting our next change control procedure with the WHO PQ team. So next slide, please. So here is a short description of our new presentation of yellow fever vaccine, which is called Sensavac. And here is just some advantages compared to our traditional vaccine into ampoules. So the next slide. So the just the minimal difference between both products is more obvious in this slide, and I would like to emphasize that the new form is being produced at the same facility by the same production team, tested for quality and safety by the same QC team, and assured by the same quality assurance team. So in the other words, it's actually the same product by a little bit with some advantages in which makes it really more convenient in use for the recipients. So next slide, please. So on the slide, you can see our production plans for the ampoule-filled vaccine and the same production plans for the vials for the Sinovac. So you can notice that if the vaccine demand remains high, our production capacity will be able to enlarge the production facility more than 50 million doses per year. And that is only the beginning, so we are looking to increase it more and more on the couple of next years. So next slide. So as I said before, so UNICEF has already started procurement of our new vaccine and dedicated for the campaigns and outbreak responses. So you can see the numbers of the procurement and supplies. So the next slide, please. So the next slide is dealing with the challenges and potential constraints which we are facing due to the unstable situation in the world, in Russia, and the current situation in Russia. So we've just here we've tried to list the most crucial factors which may impact our production activities as risks, but we are doing all the best together with our UNICEF and WHO colleagues just to avoid all these risks. And I want to say just thanks, to express my appreciate for the colleagues who is really helping us to avoid all the potential risks which we can face. So I think that is just that is all what we wanted to say. And if you have any questions, just really feel free to ask them or to write them after our meeting. Thank you very much for your attention.
Thank you very much, and Chumakov Federal Scientific Center for your presentation and for also keeping within the time slot. So I would like to move to our colleagues also online from the Serum Institute for their presentation. Thanks, over to you.
Good afternoon to all.
Good afternoon.
Yeah, I cannot see the slides here.
Just give us 1 minute. Thank you.
Yeah. Good afternoon once again to all who are present in this meeting, offline, online. I'm Milan Ganguly. I'm looking after the yellow fever vaccine project in Serum Institute of India. and I will. I hope everyone can hear. Yeah. So I will give an update of the SIIPL yellow fever vaccine, the current development status of the vaccine. Next slide, please.
Excuse me, can we pause for a minute? I will get back to you in a moment. Sorry, apologies for interrupting.
You can just tell the details.
I just want to note that the slide said that the information in the PowerPoint presentation is confidential and proprietary. Just to reiterate that this is a public meeting, are you comfortable to continue presenting the information on this slide?
Okay, okay, we can proceed.
I think that is okay.
Yeah, okay.
Okay, thank you very much. Yeah, you can go ahead.
So I will now present the current development status of the SIIPL yellow fever vaccine. We all know that this is a very critical vaccine, and so Serum Institute of India has taken the vaccine development on a fast track. The product presentation, the final product presentation of our vaccine is like this. This is a live attenuated freeze-dried vaccine with yellow fever vaccine 17D strain. More particularly, it is containing the 17D213 strain, the WHO primary seed virus. We are using water for injection as diluent. The presentations are 1 dose, 5 dose, and 10 dose vials, amber colored. The final product storage temperature, it is a lyophilized vaccine, so it is kept at 2 to 8 degrees centigrade. The VVM assignment is VVM 14. The VVM study has been already completed. The expected shelf life is 36 months for this vaccine, and the label claim is as per WHO and pharmacopoeia requirements. Next slide, please. Being the vaccine on a fast track, looking at the urgency of the vaccine to be available in the market. So we have already completed the all mandatory initial studies like neurovirulence study for this vaccine, then the animal toxicity, then phase 1 clinical trial, and we have completed the phase 3 clinical trials also in Africa that later my colleagues from clinical trial group will explain. We look at WHO PQ submission by September 24. This is a prospective timeline, and we expect the grant of WHO PQ by Q3 of 2025, with an assumption that the local NRA BCGI grants the export-only license for the unit supplies, and WHO will expedite the timeline, means in terms of the acceptance of the dossier, the review, and other things. Next slide, please. The production capacity of our yellow fever vaccine, a new plant we have developed in our compound in Pune. Capacity for the year 2025, we are assuming that we will receive the PQ, WHO PQ by year 2025. So the first year capacity will be partial, and it is approximately 25 million doses of the final product, and it can be distributed because normally the need for preventive means UNICEF, PAHO, and WHO like agencies 5 dose and 10 dose multi-dose vials. So it can be distributed. This capacity can be distributed accordingly as per the need. The first year will be 25 million, and from year 2026 it will be 100 million per year. Next slide. We can further look at expediting the SIIPL yellow fever vaccine availability. And if there is early WHO PQ application and rolling submission of that data, if accepted by WHO, this can save valuable time for evaluation of the available data. We already have a lot of available data because we have already completed the phase 3. And so some available data on CMC, process validation, product stability, etc. can be submitted earlier for an earlier evaluation, which can start if acceptable to WHO. We are also looking at obtaining the export only license for event supplies from the Indian regulator, and based on the request letter or communication from WHO, UNICEF, emphasizing the urgency of the vaccine in the global market. Next slide, please. So, SIFL yellow fever clinical development, my colleague Dr. Anirudh Pote will actually present the clinical development part.
Good afternoon, everyone. Next, please. So this is the overall clinical development plan for the product. The phase 1 trial was successfully completed in India in healthy adults of 18 to 45 years, and this study has been published. It is in public domain. After the completion of the phase 1 study, we evaluated the routes by both subcutaneous and intramuscular in the phase 1. Along with the comparator, and the study showed that the vaccine was immunogenic and safe, similar to that of the active comparator. So going ahead, we went into the phase 3 trials. The first phase 3 trial was done in Mali and Gambia with the objective to demonstrate the safety and immunogenicity with the licensed vaccine. The study population was about 9 to 12 months of age. So this particular trial was conducted keeping in mind that this would help to include the vaccine in the routine immunization plan of the endemic countries. So the age group was 9 to 12 months with a total sample size of 2,216. This is the largest sample size for any other pure vaccine study in history. Thus, the complete study report for this trial is expected at the end of Q2 2024. The second trial is the phase 3 Kenya with the intention to demonstrate the safety and immunogenicity with the licensed vaccine. So this trial, the age group is 1 to 60 years. This is basically this trial will help to establish the vaccine for the market of catch-up campaigns or outbreak campaigns. The total sample size is 1,824, and it is divided into multiple age groups. The study report is expected at the end of Q3 2024. Next, please. So for the local licensure in India, we are also conducting a phase 2 trial in India as well. So this is as per the local regulatory requirements. This trial especially for the travelers. So the study population is more than 18 years. This study has already been initiated in India with a total sample size of 580. We anticipate this study to be completed by the end of 2024. Next, please. Thank you.
Yeah, thank you very much, team from Serum Institute. They just stand by so that we get the other two presentations, and then we can go to the discussion and question and answer session. So on my right is the representative of Biomanguinous, and if you can get a presentation up, and she can start. Thank you.
Hi, everyone. I'm proud to take part in this strategic annual meeting in Ethiopia, the land of origins. I would like to ask for thank you in advance for comprehension, but I will do the presentation in Portuguese like my colleague Eder, okay?
Hi, sorry. I did mention before that none of the breakout sessions have interpretation.
Oh. No.
Any Spanish speaking person could translate.
Portuguese.
Yeah, but any Portuguese speaking person translate.
Thanks, Diana.
Extractive.
You have to Diana will translate.
Try.
Sorry.
Apologies.
Let's go.
Oh, yes, apologies. Yes, we can do the Portuguese to English with the Portuguese colleagues, the Brazilian colleagues. Sorry. No, that's you know, it's like would you maybe or able to translate into English afterwards? Yeah. Okay.
You can?
Yeah.
Okay.
I try.
Let's go. I can help you. Let's go. Next slide, please. Eu trouxe a agenda, eu vou apresentar o compromisso de Biomanguinhos.
So this is the agenda. I'm going to present the commitment of Biomanguinhos.
Fornecimento global.
For the global supply.
Eu vou mostrar os esforços de fornecimento.
I will show the efforts for supply.
De processos de melhoria e inovação.
Process of improvement and innovate.
E a projeção de produção e disponibilidade de fornecimento.
And the projection of production and supply availability.
Yes. Next slide, please. Nesse slide, eu trouxe um pouco que Biomanguinhos atua para atender as demandas de saúde pública global.
In this slide, I'm showing you how Biomanguinhos works to meet the demands on global public health.
Tanto do Ministério da Saúde no Brasil,
from the Ministry of Health of Brazil,
como dos organismos internacionais.
As the other international organization.
A gente atua na promoção de saúde pública por meio do desenvolvimento.
So we want to develop public health by development, innovation,
produção e fornecimento.
Production and strengthening of vaccines.
De kits diagnóstico.
Diagnostic kits.
Yes. Medicamentos biológicos, biofarmacêuticos.
Biological medicines.
Prestação de serviços.
And providing services.
Tá. Desde que Biomanguinhos foi pré-qualificado para a vacina de febre amarela, nós já exportamos mais de 190 milhões de doses desde 2001. Foram mais de 190 milhões de doses exportadas.
Devagar. Since Biomanguinhos was approved to produce the yellow fever vaccine, in the past 22 years, they have developed more than 18 million doses. No, 190 million doses for yellow fever vaccine to over 70
countries.
Patricia, I've just been contacted by the Portuguese interpreters. They're happy to do some translation for you for this session. So thank you very much to them. That's super kind. Thank you.
Okay.
So, but you were both doing a great job. If this doesn't work out, there's always another career waiting. But continue.
Thank you. Next slide, please. Bom, Biomanguinhos abastece os países, né, por meio da Organização Mundial de Saúde, a OPAS e a Unicef. No portfólio de exportação, nós temos a vacina de febre amarela e a vacina meningocócica, que é uma parceria com o Instituto Finlay de Cuba. Next slide, please. Next, please. Nesse slide eu trouxe um histórico dos nossos esforços desde 2017 e nós colocamos 2017 porque 2017 foi um ano atípico, onde nós tivemos o surto de febre amarela no Brasil, 17, 18, onde foi um ano que nós não conseguimos exportar a vacina de febre amarela porque toda a nossa capacidade naquele ano foi voltada para o Ministério da Saúde. Então, foram 64 milhões de doses de vacina de febre amarela para atender o Ministério da Saúde. Então, eu coloquei como marco o ano de 2017 e 18, e 18 a gente teve também o surto de sarampo, 18 a 19, que também impactou as nossas exportações, já que a nossa vacina de febre amarela para exportação, assim como a tríplice viral que a gente entrega ao PNI, é na apresentação 10 doses. Então, tanto o surto de febre amarela como de sarampo impactou nas nossas exportações, porque a gente voltou a nossa capacidade produtiva para o Ministério da Saúde no Brasil. Sendo que, em 2020, nós tivemos a pandemia da Covid, e nesse gráfico a gente está mostrando um pouco do fornecimento em 2021, trazendo o que o Éder falou, né, que de 2020, com o estoque cheio, para 2021 nós entregamos menos ao Ministério, porque a demanda foi menor, porque eles estavam com o estoque com uma quantidade, né, significativa. Nós também começamos a retomar a produção de exportação, porque 2020 foi voltada para a produção da vacina Covid. Então, a partir de 21, 22 é que nós retomamos uma capacidade produtiva onde a gente exportou. Em 2022, que é a parte azul, nós exportamos 8 milhões de doses de vacina, 2023, 15 milhões, ponto 4, 2024 a gente está preparado para exportar 28 milhões de doses. E para o Ministério da Saúde, nós entregamos em 2022 20 milhões de doses, 20,8, entregamos em 2023 14,4 milhões de doses, e para 2024 nosso compromisso com o Ministério da Saúde é de 21 milhões de doses. A gente tem quase 50 milhões de doses de vacina de febre amarela para entregar em 2024, entre os organismos internacionais e o Ministério da Saúde no Brasil. É importante destacar nesse slide que toda a entrega que a gente vai fazer da vacina é na apresentação 10 doses, tanto para a Unicef quanto para a OPAS, exceto para o Ministério da Saúde, a apresentação em 5 doses, tá? Mas eu vou mostrar no slide à frente a nossa capacidade produtiva entre 5 doses e 10 doses. Next slide, please. Aqui eu trouxe um slide com os últimos 5 anos de fornecimento. Esse slide é do Ministério da Saúde no Brasil, onde em 2020, né, onde a gente está falando em 73 milhões de doses desde 2020 entregues ao Ministério, 35 milhões em 2020, 2 milhões, quase 3 em 2021, 20 milhões, quase 21 em 2022 e 15 milhões em 2023. E agora, em 2024, a gente tem um compromisso de entrega de 21 milhões de doses. Next slide, please. Nesse slide, eu trago o fornecimento por meio da Unicef para os países da África. Eu trouxe aqui no slide que desde 2020 até 2024, a confirmar, a gente entregou 25 milhões de doses, sendo que nós temos uma expectativa de fornecimento para a Unicef em 2024 de 20 milhões de doses de vacina. Eu trouxe os países que nós tivemos maior quantitativo de exportação, mas nós, de fato, exportamos, atendemos quase todos os países da África. Eu só chamei atenção para a Nigéria, porque 9 milhões de doses, para a República Democrática do Congo, com quase 6 milhões de doses. Então, eu chamei a atenção de alguns países, mas nós exportamos para praticamente todo o continente africano. Next slide, please. Nesse slide, nossas exportações por meio da OPAS, também chamei atenção para alguns países, sendo que desde 2020 nós exportamos 10 milhões de doses, também a confirmar para 2024, porque para 2024 o nosso compromisso, a expectativa com a OPAS é de 7,4 milhões de doses. Então, 20 milhões para a Unicef, 7,4 para a OPAS, e mais o compromisso com o Brasil de 21 milhões. Next slide, please. Aqui eu trouxe um slide porque quando é possível a gente participa também de licitações com a AMS diretamente, quantitativo pequeno, 137 mil doses, a gente conseguiu atender. Em 2020, nós atendemos 50 mil doses, foram fornecidas. Em 2023, 87 mil doses foram fornecidas. A gente teve um incremento de 74% de atendimento direto ao AM por meio de licitação. Next slide, please. Next. Eu vou falar agora dos processos de melhoria, os processos nossos de melhoria e de desenvolvimento e inovação. Primeira coisa importante é que agora em fevereiro, a Anvisa, a nossa agência reguladora, deferiu o pedido, o processo de retirada dos antibióticos da vacina. Isso está alinhado com o esforço global de retirada dos antibióticos, né? A gente já vinha com esse processo de melhoria há alguns anos e nós conseguimos agora, no dia 1º de fevereiro, sair o deferimento pela Anvisa da retirada dos antibióticos da nossa vacina. A gente tem também como processo de melhoria a CMO, que nós temos um contrato, a gente ampliou o contrato com a Libs, que é uma empresa que nos apoia para liofilização, apoia na produção, né, no processamento final da vacina de febre amarela, que hoje é um gargalo em Biomanguinhos, embora a gente tenha uma capacidade produtiva para bulk significativa, mas a gente tem um gargalo na liofilização, no processamento final. Então, a CMO, a Libs é uma empresa que foi contratada para apoiar, né, nesse processo. Foi um investimento feito por Biomanguinhos para a gente ter uma capacidade de processamento final maior. Além disso, a gente também está com a questão do barcode, que a gente vem conversando com a Unicef já tem algum tempo, né, que é o leitor de código de barras. A gente está com a expectativa de implementar já a partir de 2025 para as nossas exportações. Então, isso é uma expectativa que nós temos, estamos trabalhando para isso, modernizando, comprando equipamentos, na verdade. O investimento em aquisição de equipamentos para que a gente possa implementar o leitor de código de barras nas embalagens secundárias. E as questões de sustentabilidade, que nós também estamos investindo em modernização de equipamentos, alguns equipamentos para redução de emissão de gás carbônico. Ok? Uma coisa importante também que eu trago é que nós tivemos agora, em fevereiro, no final de fevereiro, a gente recebeu a inspeção da Anvisa e da OMS, e nós estamos aguardando o resultado do relatório deles e, de acordo com o que vier no resultado do relatório da Anvisa e da OMS, talvez a gente tenha impacto de precisar fazer algum tipo de adequação, a depender do que eles trouxerem no relatório. Importante colocar isso aqui. Next slide, please.
1 minute more, please.
Aqui eu trago também outra melhoria, que é a melhoria de processos, que a gente fala em otimização da produção da IFA, por meio da redução do número de embriões. Então, a gente está falando de uma otimização de produção de IFA, que hoje está em cerca de 63 milhões de doses para quase 107 milhões de doses por ano. Isso é uma expectativa que está atrelada à otimização do processo produtivo com a retirada dos embriões do processo. Além disso, a gente também está com uma construção, né, de um módulo de produção modular, que está a foto ali à direita. Os dois são a foto desse módulo que a gente está construindo em Biomanguinhos, também para ampliar a capacidade produtiva nossa da vacina febre amarela. Next slide, please. Aqui eu trago o campus, o novo campus de produção nos arredores do Rio de Janeiro, que é o campus Santa Cruz, que a gente está na etapa 2, né, do projeto, um projeto que está na fase 2. Então, a gente está falando de uma estimativa de, quando ele estiver pronto, uma capacidade anual de 120 milhões de frascos de vacinas, e tamanho dele 580 mil metros quadrados, vai ser o tamanho do campus, uma expectativa, né, de 1.600 empregos diretos e 5.000 indiretos. E hoje a gente está na fase 2, com a expectativa de, talvez nos próximos 3 a 4 anos, a gente está com os lotes de consistência em liberação.
Yeah, sorry, we need to wrap up. Yeah. Maybe just the key points in the next slide, and then we can just wrap up so that we can take the Sanofi presentation.
Okay, just to, it has the last slide. It has one slide more.
Okay.
Okay. And this is the last slide. Oh, esse é o último slide. Onde eu trago a nossa projeção de capacidade, né? Hoje a gente tem uma capacidade de produto final em apresentação de 5 doses, 24 milhões de doses, e na apresentação 10 doses, 25 milhões. Então, a nossa capacidade nominal, a nossa capacidade em produto final, hoje, de febre amarela, a gente está falando em 49 milhões de doses, onde em 2024 a gente está batendo nessa capacidade porque nós temos 21 milhões de doses para entregar para o Ministério da Saúde do Brasil, 20 milhões para a Unicef e 7,48 milhões para a OPAS. Com isso, a gente soma 48 milhões de doses a serem entregues em 2024. E a capacidade efetiva que nós temos em 5 doses, 24 milhões, em 10 doses, 25 milhões. A gente tem como impacto, o que a gente pode ter de impacto nessa capacidade produtiva nossa atual? Algum surto que possa surgir, como aconteceu em 2017 de febre amarela, em 2018 de sarampo, e a gente tem que direcionar toda a nossa capacidade produtiva para atender o Ministério da Saúde no Brasil, então isso é importante. No momento, como o Éder trouxe, a gente está com a epidemia de dengue no Brasil, então isso pode impactar se a gente produzir a vacina. A gente tem uma questão como instituto, né? Nós somos um instituto público, então a gente tem toda uma burocracia para os processos de compras. Nossos processos de compra não são um processo de compra de procurement, não é um processo rápido, então é um processo longo, com burocracia, com avaliação pelos órgãos de controle, auditorias realizadas a todo momento, que a gente tem que garantir uma eficiência na utilização do recurso público. Então, isso também impacta na nossa capacidade produtiva no que tange a quanto, com maior antecedência, a gente recebeu o planejamento das agências internacionais e do Ministério da Saúde, a gente consegue se organizar melhor. E, por fim, o impacto da implementação da Organização Mundial de Saúde do Anexo 2.
Sorry, we have to call time.
Obrigada. Obrigada.
Thank you very much.
No, you're
So we'll move to Sanofi. Last but not least, thank you very much for your patience.
Last but not least, thank you for the opportunity. I am embarking in this new role and really have been excited to hear all what I heard from the first day. And I must say it's very impressive all what is carried out around yellow fever vaccine. So my presentation, you can go to the next slide. We have been talking in past days about synergistic collaboration. I think Sanofi is definitely committed to the international fight against yellow fever for more than 70 years, actually, and we have provided 500 million doses since 1953. And we joined the I initiative in 2016, and Sanofi is contributing on the 3 strategic objectives of the I strategy on protect at-risk population, because we are committed to provide doses to routine programs and preventive massive campaign, and also on the international spread, because we supply both two types of yellow fever vaccines to support the implementation of international health regulation, and also we avoid yellow fever expansion within travelers. And our third strategic objectives, we are also committed to the global international coordinating groups for outbreak response. On the next slide. So our vaccine, Stamaril, is WHO pre-qualified and has been really shown safe and highly effective in preventing yellow fever, both in endemic and international travelers. It's a high-value vaccine with a 1 full dose and lifetime protection, which is, from a programmatic standpoint, very straightforward. And we produced and divided all the committed quantities that were required. And you can see here the past volumes that have been provided through UNICEF on one side, 33 million doses in 23 and 24, and 4.5 million doses for PAHO in 23 and 24. We are pending, of course, for the next tenders for 2025 onwards, and we are ready to answer to this tender. Next slide, please. So as you see, we have been continuously investing on our yellow fever vaccine from different dimensions, from a quality standpoint, regulatory standpoint, compliance standpoint, and also capacity. From 2014, we have been increasing our demand, our supply, to respond to the global demand. And also, we are in a very advanced stage of development of a new generation yellow fever vaccine with very promising clinical results. This is our new generation yellow fever vaccine, which is on a new cell culture technology, meaning no longer dependent on the sourcing of specific pathogen-free eggs. It's a live-attenuated yellow fever vaccine, which is produced on serum-free viral cells, which is a technology that we have been using for decades for other vaccines also in our portfolio, and widely accepted, of course, by the regulatory authorities. So this new generation vaccine is a lyophilized, also purified vaccine, and it's exempt of allergens, antibiotics, and logically also exempt of chicken egg proteins. And this vaccine will replace our two vaccines that are commercialized currently, named Stamaril and Wyovax. We have, through the new generation vaccine, an improved production process to further really secure sustainable supply. The next slide. So I would like to end my presentation by underlying the very important requirement here, which is that we need to have a significant anticipation in terms of production. It's a viral vaccine manufacturing implies really a significant lead time between formal demand and supply for three reasons. It's a biological nature of microorganisms, so it requires about 1.5 to 2 years from viral culture to release on vaccine doses. And 70% of this life cycle time is for quality controls. The second reason for that also is that we have human resources and high level know-how, which are required for this technology as well, which requires anticipation, and also the production plan. So within facilities and also human resource allocation and prioritization, even versus other vaccines that we are producing. So my last word would be really a call to action. I think it's for us, and I would say for all manufacturers, really important to have a reliable long-term forecast, which is critical for us to put the level of investment at the right level and to secure a production sustainable across the years and secure an access to the vaccine for you. Thank you very much for your attention.
Yeah, thank you very much. I think we have some 5 minutes for questions. There are some questions online, but we'll take the questions inside the whole facade. Lawrence wants to talk, so go ahead, Lawrence.
Thank you very much, Kola, and thank you very much to all the yellow fever vaccine manufacturers. I say it every time, but I think it's critical. We would not be where we are if it were not for you, if it were not for your efforts, your commitment, and the amount of vaccines which have been produced. So I want to really send my greatest appreciation. I was about to say on behalf of the global yellow fever community, but I think it's on behalf of the communities that you help protecting. So thank you so very much. It's been, for us, you're integral to the I partnership and you're a critical enabler. So really wanted to appreciate that. Thank you.
Yeah, thank you very much, Lawrence. So do we have questions in the house? Yeah, Diana?
I have a naive question. So with this new cell culture technology, is Sanofi planning to do any kind of immunogenicity or rectogenicity trial, or we'll just assume that it's exactly the same as the previous yellow fever vaccine? Just out of curiosity.
So we have a global development plan, phase 2, phase 3, and we aim, and the target is to have the same, to target the scopes, the standard of care, meaning yellow fever, vax, and Stamaril. Yes, absolutely.
Okay, we have a question from UNICEF, and then I'll go to our, John Luke.
Question. The first is about the first question is to the first presenter. I've noticed that they are experiencing some challenges related to the current situation in the country, their manufacturer country. So are there any plan for longer term to address these challenges, either in shifting to another country, to relocate to another country, or they think they hope things might improve and keep working on the same challenge? Because I'm not sure in case of if they will address the need according to the outbreak or any other situation. So the second question is about Sanofi, just to know about the shifting plan from the previous to the new vaccine, or all will continue working together.
Yeah, it would be, I could say, transparent for you. So there will be a progressive shifting of the supply from the current vaccine to the new generation vaccine.
Next year.
Sorry?
The timeline?
Oh, timeline, it's difficult to say exactly the year at this stage. We are in the good, timely, from a clinical standpoint, we are in good timelines, but I cannot provide exactly the launch date at this stage.
Okay.
Sorry.
Yeah, so the first question was addressed to Dr. Malkin and colleague. Feel free to answer or pass on it as much as you are comfortable. Thank you.
Can you hear me?
Yes, we can hear you. Do you get the question?
So I would like to underline that all the potential constraints specified in our presentation are fully controllable now and hopefully overcomable. They are not critical. So it is not necessary to allocate production immediately.
Okay, thank you very much. Alvaro?
Thank you very much to all the presenters. Very interesting information, especially for the immunization programs. I am wondering if in your work plans or at some point Are you planning to research on new platforms besides the one that has been mentioned by Sanofi regarding, for example, an inactivated vaccine or something like that? Thanks.
Okay. I have a comment. Well, Biomanguinhos is a producer from Ministry of Health of Brazil. So, and it's a public company, very important to us, and it's a main supplier of our NIP. And as Patricia showed, the demand of Ministry of Health is increasing because we are increasing our vaccination, considering the new strategies that we adopted in our country. And as you can see, all the 5-dose vials is to attend the Ministry of Health demand. And in this morning, I listened the discussion of Maggie Archbold that give us some points that are important, and you agree that 5 doses is better for the program because the number it's not a problem of yellow fever. I think that all the multiple doses of our program, we try to reduce the number of doses of all vaccines because it's easier to the health professional that work in the clinic to vaccinate. It's easier, and we try to see the loss of doses. Which we are working to reduce the loss of doses. But I think that Biomanguinhos need to increase the production of 5-dose vial, and it's a challenge, I believe. And now, because of dengue vaccine, we are see the options that we have to increase the supply of dengue vaccine because the pressure is too high, and we are studying to produce dengue vaccine in Biomanguinhos with an agreement with Takeda, but it would impact in the dengue production. So I think that it's not a good option for us because it will impact in the 5-dose in the 5-dose line production, right? So it's a big problem. So and I believe that 5 doses is what we want, and I think that the world wants 5 doses. So we need to study and maybe increase the production of 5 doses. But it's not easy. This change, it's not easy. Like we need many years to change a production. So we have a huge challenge in front of us. Thank you.
Thank you very much for the clarification. I think we are really short on time, but I don't want to neglect the question we have online. There are 3 of them. One is already answered. So the remaining 2 are, I think they are quick questions, and any of the manufacturers can then just volunteer to answer. So the first one is if there are partnerships with any organizations or governments to ensure that the vaccines are made available to at-risk countries that are non-Gavi eligible. And the second question is about safety surveillance of yellow fever vaccine, if all the companies are still committed and if they are publishing the outcome of the surveillance that they have for safety data for yellow fever vaccine, especially in special populations. Thank you.
May I do a comment about the what? About because about the comment of Ada about we have no capacity to produce 5-dose presentation in the next years. I hope when the new facility in Santa Cruz is ready, we can we can attend this presentation. But now this will be a big challenge, and I have to be honest, because we cannot attend 5 of those presentations because we need, yes, okay. Thank you.
Okay, anybody willing to, yeah, you have another question? Okay, just wondering if any of the companies has a comment to the questions online, and then before we go to Cassandra and with the last question. The first question is about commitment to collecting and transmitting safety data for yellow fever vaccine, especially in special populations. And the second one is if there are any ongoing partnerships to make the vaccine available to non-Gavi eligible countries. Okay, I think we are wrapping. Okay, then you could put it in the chat or something, but Cassandra should come with a question and then we can wrap up.
Thank you. Mine hopefully is very, very quick. Just a point of clarification for our colleagues in SII. It was mentioned that the phase 3 study, it seemed to finish and completed by the end of year, meaning by the end of 2024, with and they're expecting or looking forward to an expedited PQ pathway. I was just wondering, when would it be your expected submission for PQ? Given your clinical trials ongoing. Thanks.
Yeah, so we are expecting the PQ submission as we have completed the one trial in 9 to 12 months age group. We plan to have the plan for PQ submission for that particular age group this year only, hopefully at the beginning of Q4 2024.
Sorry, you didn't come across very clearly. Can you repeat yourself? Sorry.
Yeah, so we have since we have completed the trial in the age group of 9 to 12 months, we plan to go for the initial PQ submission for this age group in around September 2024.
Okay, thank you very much. That's clear. Okay, so I would like to thank everybody for their participation. Most especially, I want to reiterate Dr. Sibelo's initial comment that we are very grateful to the vaccine manufacturers and all the very impressive statistics that has been read out with regards to the gains for the eye strategy, protecting at-risk populations have been, none of them could have been done without the fantastic support that we've gotten from the manufacturer. So thank you very much, and I would like to close this session. Thank you.
Thank you.
Back to the chair. Apologies.
And then the next, I think it's so my first words would be in Amharic, the few I've learned over the few days, and the true. So good afternoon to all. I see Dr. Malcolm was smiling. He did smile the first time around. And actually, that's to you that my thanks want to go first. I really want to appreciate your presence throughout the entire meeting, your engagement. And through you, I want to thank also the government of Ethiopia for welcoming us here. I want to thank the government of Ethiopia for its commitment to introduce yellow fever vaccine into routine immunizations and to implement the large-scale nationwide campaigns. It's a turning point for Ethiopia and the communities of Ethiopia. It is a turning point for the eye strategy as well. So I really want to appreciate that very much. And without you, we would not be successful at eliminating yellow fever epidemics in Africa and globally. So thank you very much for this engagement, and thank you for welcoming us throughout those 3 days. I also really want to thank all the partners here, all the participants. Thank you for your presence and your engagement. If we look at the next slide, please. I think it's been a very engaged and important meeting. I want to appreciate also that we have had the chance to have in the room 2 giants of yellow fever that do represent a large piece of the history of the disease, the efforts for the control, the challenges, and the passion and commitment. For me, it's been very humbling and touching. I've been very impressed. It's been a pleasure to have you both, Professor Vasconcelos and Professor Tomori. Your yellow fever history, and it's been a privilege to have you with us. Thank you so much. And I also want to thank all the persons who worked behind the scene to make this meeting possible. And I would ask that you bear with me again for the pronunciations. I do try my best, and do know that you have my heartfelt thanks, if not my correct pronunciations. But I want to thank, obviously, Dr. Nolanda Dlamini, Dr. Rose, and Dr. Patrick Abok from the country office, who allowed us to have a full access of the team and facilitated this meeting as well. So thank you to them. Thank you to Michael Tukru, Mr. Fiklu, who arranged also the meeting, Lelem Bezahe, Fasil Aile Mariam, Dr. Tesfaye, our friends in the I strategy, Meron Walde Michael, Selema with Yilma, Alelse Gebredaye, Belete Belai, and also at the UNCC, and I do hope they can join us or are in the room. Are they or are they not? Okay. Isera Pontu Gola, Fehiwat Gebarne Meskel, Senanowit Girme, Aminael Belai, and the fantastic Qatari team and security who have looked us so well, Solomon as well. But last but not least, I want to also thank Ilham, who's been instrumental. So I wanted to keep my thanks to you for the last piece before turning on to the I Secretariat. Also, my heartfelt thanks to Raki for organizing the meeting. And the entirety of the officers from the group who've helped working with you all in the preparation and during this meeting, and who've shared important insight, as you see it, and are pushing the agenda or the work of the I Secretariat forward. So thank you very much to Gou Maison. I go by strategic objective. I'm sorry, I just have them in my mindset. So strategic objective 1 is Kola Salami. That's how I think all the time. Strategic objective 2 is Maria Bragano. And strategic objective 3 is Joao Toledo. Thank you all very much. So it's been, as we say here, I think it's been productive, it's been engaged, it's been insightful and thought-provoking, including through your chairing. And it's been, I think, for me, really quite powerful to see that 7 years in, we still have this level of engagement, we still have this level of commitment and the eagerness to make a difference. So it's important. We are custodians of a critical global health agenda with potential to threaten global health security. So we're in this together, and thank you again for your engagement. It's been very moving. And a key element for me is a key reflection is to appreciate how we're both able to shape the global agenda and the global thinking around yellow fever, but also, as you saw throughout the 3 days, how grounded into the realities of the countries we are. I think it's critical how oriented toward addressing their needs we are. And I do want to appreciate the country colleagues who have provided a presentation, insight, and expertise during those meetings. And I want to appreciate also the colleagues from PAHO of the country in the Americas who unfortunately could not travel and be with us, but they were connected online, and I want to appreciate that very much as well. And also, I think another key features of this partnership is how result-oriented we are, and that's something to be very proud of. Together throughout the meeting, we've talked about the progresses, and on this, I want to really appreciate the updates that we've received from the African regions in light, and the update on the progress in light of the a framework for our implementation that was approved at the regional committee meeting in 2017, and also appreciate the presentations from the PAHO colleagues who are working toward finalizing a roadmap for our implementation in the Americas. That would be also very insightful. I believe we may have our colleague from EMRO online, Dr. Kyori Kodoma. If you're connected, Kyori, could you just let us know and possibly turn your video? I also really want to appreciate how through your leadership, EMRO is at the forefront of the efforts on preparedness, surveillance, laboratory capacity, and IXR. These are the key tools that, sorry, besides Sudan, we have for yellow fever risk mitigation in the region, and through your advances, I think that would be a great example for Africa as well and the other countries. I'll just have a little bit of water, if you don't mind, my apologies. So together we looked at the progresses and some key emerging issues. I want to flag obviously the resurgence of the yellow fever outbreaks, the continued and serious urban threat. And we also looked at continued challenges. This is where I put routine immunization, the challenges with routine immunization, but also the challenges with data quality, the challenges with the identification, confirmation, and interventions linked to outbreak. We do have major delays, as well as the challenges with reaching neglected communities, and possibly with prioritization. I have a few take, and it's actually very nice that my voice is playing out, so I will rapidly stop. But the few take I take from here is, I remember when we met last in Brasilia, I had since insisted on the importance of the country level and having countries leading the charge against yellow fever and challenging the partnership and the partners to respond to the needs. I think after this year's meeting, my thoughts and really go to the communities. So from countries, I think we've moved to communities. This is where we need to make a difference, and this is where everything starts. I want also to insist on the importance of having coordinated actions among partners to ensure that we make our contributions more relevant, and we make it easier, in air quotes, for the country to implement the eye strategy and address yellow fever risk. And again, the last and final point for me is the take on routine immunization as being the way to ensure the sustainability of yellow fever prevention and control. As I said, my voice is playing out, and it's the perfect segue because I wanted to close the meeting with the partners. Again, I'm representing the Secretariat, but I really want to hear from all of you around the table. So we'll start with Dr. Malcolm, if you want to say a few words, and then I will invite the Afro Regional Office, I will invite the US CDC, I will invite UNICEF, I will invite Prof. Tomori as well, the Gates Foundation, Pao and Gabi, to please share your thoughts. And again, you do have my utmost appreciation.
Yeah, please, can we join our hands for Doris? Learning how, she's passionate to share us her thoughts, struggling in such a way. So I'm really impressed. That's why I requested you to join your hands for appreciation. So really, for me, it's my honor to be here, and on the behalf of Ethiopian government and the Minister of Health and my team here. So my team and I were here, for the entire meeting, given that we are, infant in the case of yellow fever. So we were open and we were genuine to learn and sometimes to share what we have for the participants. So in the case of yellow fever, it is a historical event for us to learn from the I Secretariat, the whole partner stakeholders here, and from countries. So we prioritize this meeting, and we are attending this, giving a high priority, given that we have, different challenging situations in this time. So I want to appreciate the I Secretariat and the organizers, including the country office WHO, to trust Ethiopia and to make this happen in the country, and we were very, very happy to host this meeting. So for us, we appreciate the follow-ups from the global world, particularly for the I Secretariat. We were appreciating how you are, following us, without fatigue. So we know that, and we clearly understand that as a country, we must, contribute for the agreements that we made as a state, a member state, and we want to, contribute for the global agenda, though we have, such a priority. So we already started. We are in track for the introduction of the routine immunization and the preventive mass vaccination. So we made a historical decision to introduce this, but the issue is now, the timing. So we are kindly requesting again our partners to expedite the timing. The more we get the support from our partners, the more, we can achieve this global target within the time. So this is the point that we want to, share for the global. And from me, as we had, some discussions in the side meeting, the side meetings that were really important. I also appreciate those who organized this. And I have some points that we'll take to the government of Ethiopia to discuss and, to table this issue for more attention. And I hope all partners also get some insights and, how the real situation in the country is. And I hope you will also take some understandings and discussions on this. So we expect, we will follow you, and we expect some, responses from your side again. So this was, what I want to say in relation to the meeting. And in the remaining times that you have, I wish you a best and a pleasant event in the evenings. And for those of you who have more time, I want to invite you, to visit, some parts of the country. But for those of you, who plan to go back to your home tomorrow or this evening, I wish you, a safe travel to your lovely family and home. Thank you.
Okay, thank you very much. I think all has been said from our side. I want also to appreciate the I Secretariat for all the support that the region has been receiving in implementing the I strategy. I want to thank all the countries that have been very participative and contributing to the discussions. I also want to thank our PAOS colleagues. It has been a very good opportunity to collaborate and to learn a lot from their experiences. And I think from our side, we'll continue to be available to support countries to move ahead with our objectives. And we are looking forward to implement the resolutions and the action points that have derived from this meeting. Thank you.
Thanks. I'll keep my comments brief, but I again wanted to thank very much the I Secretariat for bringing everybody together at the annual partners meeting. We haven't had as many as we wanted to because of intervening things like COVID, but I think it's important to give us the opportunity to talk, to share knowledge, to understand. More importantly, I want to thank the Ministry of Health for being gracious hosts, but also for carrying the torch, as we say in English, forward to ensure that people in Ethiopia are not at risk of getting yellow fever, not at risk of dying due to yellow fever. So those are the two thank yous. And I just want to recall, beyond COVID, the most recent large epidemics that we've faced have all been mosquito-borne. You know, Zika, chikungunya, and now dengue. You know, thankfully for yellow fever, we have a vaccine, but we have to work together and collaborate together to ensure that we can get those doses into people's arms and prevent yellow fever from following the path of all of our other friends. So with that, I'd like to thank everybody for their collaboration, and would like to encourage people to continue.
Thank you so much. I will first and foremost, I would like to thank the I Secretariat for the excellent organization of this meeting. And I would also like to extend my appreciation to the partners who are supporting I Secretariat and our member state. Thanks to them, our member states were able to achieve some tremendous results. But I will insist on the fact that despite some progress have been made, there is still a need for support in some area. And we need to continue working closely to make sure that the program is implemented for the rest of the time by the end of 26 or 27. And as mentioned by Erin, in addition to yellow fever, we should continue working on other arboviral diseases, and not only arboviral disease, but I would say VHF or high threat pathogen. And here I wanted also to call on our partners to continue supporting our region to be able to support our member state. And we will continue collaborating with UNICEF. And now, WHO and UNICEF in the region, we are working closely as one UN to make sure that we are providing the needed support to our different member states. I will stop there. Thank you.
I can just say thank you and allow you to continue. But otherwise, just to really appreciate the dedication of the Secretariat, of the I Secretariat as much as possible. And just to look back to see that within the last 7 years, 264 million recipients have received the vaccine. And that's basically through the preventive mass vaccination campaigns. And with Ethiopia coming on board with 110 million more, you can imagine what the level of achievement will be by 2026. And understandably, there are some challenges, and as was already mentioned in the midterm review, issues of resources are really issues that need a lot of support from member states. And without resources, nothing much can be done. But we are seeing that at least the tide is shifting a little bit, at least, so that with the little, the limited capacity within the Secretariat, support is being given as much as possible to countries in the context of the ICG applications, for countries to be supported to go through the first phase of the process, which is from detection to the submission of the applications, which is really a very important step. Otherwise, response to the outbreaks will take longer than would have been desired. And as you have seen in the timelines that have been shared in the course of this meeting, and the concern that is shown globally in terms of the need to have timely response, it's really highly appreciated how the Secretariat has been providing this level of technical support. And as the ICG Secretariat already also identified, that is really a very important step, especially for the 3 countries that were identified needing additional inputs. Such meetings are opportunities for countries to share their experiences. And chairing such meetings is not really easy, because on one side, you want to give time to those responding to or asking questions or contributing to the discussions to express as much as they can. But on the other side, there are limitations in terms of number of presentations that we have to go through. So probably one consideration might be to have limited number of presentations so that people can have more time to contribute to the discussions. And as I mentioned yesterday, people have a lot to share. And that is because of the engagement that have been going on over time. For some of us, it's more of capacity building as well, because a lot has been discussed in the last 3 days. And it's more of building people's capacities to be able to be ambassadors for the Secretariat out there. So really to appreciate the work that the Secretariat is doing, but also the engagement of the partnership. And let's continue working together as much as possible to see to the achievement of the goals and objectives of I by 2026. Thank you so much.
Hi, Laurence. The interpretation will be stopping, so perhaps a final word from you to them.
My thanks as well, which I had omitted to provide before. Thank you very much for helping us through a multilingual meeting.
My tongue, and there's no interpretation. Okay. Some people look at me and think yellow fever and I were born on the same day. But no matter how many cases of yellow fever you have seen, each one is a pain in the heart when it dies. I've seen so many cases dying. So, having said that, what gladdens my heart is that so much is being done. From that first meeting to this one, a lot has happened. And I think one of the greatest things that happened is the fact that you have people, especially my colleagues, I keep talking about you from PAHO and us in Africa. We have a lot to learn from what they're doing. The first time I went to Pedro's lab, I didn't tell you the year, but both of us had black hair. There was no gray hair on our head. But today we're working with stick and we do like this. But I think it is important to keep learning from each other. And I also want to tell my colleagues in Africa, it's not that I'm saying what you're doing is not. I'm saying it starts with us. It is our community. It is our people. Yes, we are people partners, but what are we doing about it? That message must get back to our governments. It is our people that are dying, it's not the partners. Yeah. So we need to get back and see what the presentation from the other side. How did they do it? Was it a government? And then remember during the COVID, see how much money our governments poured out on COVID. How come when it comes to yellow fever, we don't? I mean, the other day I was asking the question about you give me the same day we come for vaccination for measles and for yellow fever. Yet measles gets more. Why? It's a matter of what is important to the people. The parents see their children die of measles. And so when you bring intervention, they're ready. You say, come back tomorrow for measles, they will come back. How many of them have you shown that their children have died of yellow fever? Very few. So our communication must also bring that. This is important. One death, one person dying. Let's stop there.
I think we should maybe end the closing comments there. I don't think it can be better said than Dr. Tomori.
Thank you all. Yellow fever is a tragedy.
Rise when I gave the word. Now in the morning I sleep alone. Sweep the streets I